tonight's discussion. Tonight's topic is biblical or psychological counseling. What are the benefits and weaknesses? Our first speaker is Dr. Jeremy Lelek. He serves as president of the Association of Biblical Counselors, a ministry dedicated to providing training and resources to pastors, professionals, and parishioners who seek to apply a robust biblical model of soul care to those struggling in marriage or who suffer from various emotional and mental maladies. He's also the founder and president of Metroplex Counseling, a local counseling agency with 6 locations in DFW, including Fort Worth, Bedford, Southlake, Keller, McKinney, and Richardson. Jeremy also serves on the council board of the Biblical Counseling Coalition, an international organization devoted to collaboration and the ongoing development of biblical counseling around the world. Dr. Lelek has earned a PhD in counseling education and supervision, an MA in counseling, and a BA in adolescent psychology. He's been a licensed professional counselor since 2003. In his spare time, Dr. Lelek enjoys coaching basketball at the AAU level for an organization he helped establish in 2012 called Westside Force. He has a passion to love and mentor young men and women ranging from elementary school age throughout high school age via the competitive sport of basketball. He and his wife Lynn reside in Fort Worth with their 4 children. Speaking to the topic, biblical or psychological counseling, what are the benefits and weaknesses? Please welcome Dr. Jeremy Lelek.
Thank you, brother. Thank you very much. It's an honor to be here with you this evening. My task is to, Caleb and I, Dr. Lack, we discussed how we wanted to approach this, and so my task is to first give to you guys a presentation that presents a biblical counseling perspective. And one of the things I want to start with is the title might be a little misleading, biblical or psychological. And I believe that at the end of this debate, you will see that it's more an issue of a biblical worldview versus a naturalistic worldview. History within the church goes way back to St. Augustine in terms of developing a worldview of psychology. Psychology, literally defined, is called the study of the soul. And I believe, as a Christian, that the Bible has something to say about this topic for us. Several years ago, back in 2003, when I was preparing for training to become a state supervisor so that I could oversee interns who are going towards licensure, I went to the University of North Texas, which is a very highly esteemed school. Their counseling department is extremely highly esteemed. And I remember the professor who was teaching this class began to talk to us and tell us that they require their students to embrace a particular theory at the very beginning of their training, and that all throughout the rest of their degree program for 4 years, they are doing most of their assignments through a particular theoretical lens. Many of them choose client-centered therapy established by Carl Rogers. Many of them actually embrace an Adlerian approach. And she said the reason that we do this is when you get in a counseling situation and a lot of information is coming at you, it can get confusing, it can get overwhelming. So one of the things they teach their students to do is to ask a simple question if they find themselves a bit in the weeds on what to do next in a session. And she said we tell them to ask the simple question, what does your theory say? So they want them to become experts in a particular theory to guide them in the process of therapy. When she said that, I realized that what I was engaged in at that time, very early on in my own training, I was doing the same thing, but I was asking a different question. In biblical counseling, I'm not asking the question, what does my theory say? I'm asking the question, what does my theology say? So that it's very important for me as a practitioner to be an astute theologian, someone that's studying the scripture and trying to understand how theology actually applies to the here and now struggles of our lives. In my dissertation, I questioned 20 plus experts in the field of Christian soul care, ranging from Christian psychology, Christian counseling, biblical psychology, and what's called nouthetic counseling, which is another form of biblical counseling. And what I asked them to do was to find a consensus definition on biblical counseling. And so we went through several rounds of questioning, and this is the definition that reached consensus among the experts in Christian soul care. And we'll work from this definition tonight. Biblical counseling endeavors to build a relationship with another person in which God's work of change can thrive. It is therefore dependent on the Word of God, the work of the Holy Spirit, and the grace of Jesus Christ. It seeks to build a contextualized understanding of the counselee, past and present, and will view that data through the lens of Scripture. The biblical counselor rests in the knowledge that he is not the change agent, but a tool in the hands of the one who is. The biblical counselor does not ignore physical issues or emotional data, but seeks to integrate them into a holistic understanding of the person and where change needs to take place. The biblical counselor is not adversarial in his relationship to the psychologies of his culture, but examines research and insights through the lens of Scripture. In his work with the counselee, the biblical counselor always recognizes the sovereignty of God, the transformative grace of Christ, and the insight-giving and conviction-producing ministry of the Holy Spirit. In all of this, the biblical counselor sees himself not as an isolated instrument of change, but one whose work is intimately connected to God's primary tool of change, the church, with all of its God-ordained duties, structures, and means of grace. So to begin, our epistemology. How do we know what we know? We would say in biblical counseling, our final epistemology is the Bible. The Bible is our authority regarding ultimate truth about all of life and about people, including human motivation, cognitions, affections, etc. It's the ultimate source from which we derive the answers to the great questions of psychology. It is also the lens through which we view people and their problems. The Bible, in our view, is not an encyclopedia. In other words, if someone comes to me with anxiety, I'm not going to use the Bible as an encyclopedia and look up all the passages on anxiety and quote those passages to this person. I need a comprehensive theological system that serves as my interpretive grid to conceptualize the maladies and the struggles that people are bringing to me. And biblical counseling uses Scripture to answer the great questions of psychology. Who are we? Why do we do the things that we do? What has gone wrong? What is wrong in the moment? How do we change? And what is the ultimate goal of change? So we begin with this particular diagram in that biblical counseling situates itself in the context of what we call the biblical gospel narrative of redemption. That narrative includes creation, fall, and redemption. We believe, if you look at the circle out with the little heart in it, that illustrates a person coming to counseling. And we believe that if a person is trying to find true divine transformation outside the context of this narrative, that they will fall ultimately short in terms of what God defines as transformation. We believe that a person doing this is, in my worldview, operating in an illusion because they're not including God. They're not including this redemptive narrative. And this redemptive narrative is about a person. His name is Jesus. If you read the Bible in Genesis, it's predicted he will come. The prophets are all pointing towards him. In the Old Testament, John the Baptist arrives in the New Testament and says he's here. Jesus comes, he lives his life, he fulfills his mission, is crucified, is raised from the dead. And then all of the apostles thereafter are pointing back to a person. So that ultimately, life, existence, existentially is about a person, Jesus. And we're told in many places in the Bible the activity of God in the lives of his people. Romans 8:26 through 39, I won't read it, but it basically gives us a beautiful, powerful picture of the entire Trinity working on the behalf of his people for their good and for their utter transformation. In biblical counseling, we are going to view people and the human experience in a very specific way. First of all, this outer circle, we look at human beings as sovereign God enthroned. They exist in the context and in reference to a sovereign God. From this, we would say that counseling is primarily about God. We would say that the gospel of Jesus is humanity's only hope. Salvation comes by grace through faith, through spirit-empowered faith, and that God brings purpose to and through mental and emotional suffering. And finally, that God himself is committed to empower his people towards a very specific change. We also view people as spiritually embattled. Humanity is in a fallen state, in our view, and sin is a variable that influences thinking, affections, emotions, and behavior. So we don't simply conceptualize sin as something that people do wrong, but more as a disease within the human being that flaws our understanding and creates problems for us in many realms psychologically. God is faithfully working to transform a believer's psyche, mind, and soul. Again, Romans 8:28 through 29. We also view the human person as being socially embedded. People are shaped and conditioned by social and relational influences from their past, as well as present social and relational influences, and these can at times be extremely significant. Social impact will always be considered by the biblical counselor. And we also, in our work, view suffering as something that must be taken seriously, because it's often in the context of relationship that unfortunately people do experience terrible suffering. We also look at people as physically embodied. Humanity is gloriously created in the image of God. That's one of our primary premises that drives us to love the people that we're working with. Humans are embodied souls. Therefore, we will take physiology very seriously. We're not against medication per se. We're not against medical intervention as needed. But biblical counseling is going to look at all of those spheres, but we're really going to focus a lot on this centerpiece, the heart. And we believe one of the fundamental propositions that I read in the literature of biblical counseling that is definitely supported in the Bible is that humans are fundamentally creatures of worship, every human in the world. And that at the end of the day, worship is the causal core, the primary causal core of human motivation. Two other basic presuppositions is that Jesus himself is the archetype of human flourishing and mental health. If you want to get a good picture of perfect mental health, we find that in the person of Christ. And secondly, the telos, or the ultimate goal of change, is conformity into the image of Christ, something that we call in theology the process of sanctification. So it's no wonder that in the Proverbs we read this passage, above all else, above everything else in life, guard your heart, for everything you do flows from it. And this would be a supposition that biblical counseling would absolutely adhere to. So here you see what in psychology we might refer as to nature and nurture. What ultimately makes us who we are, and what makes us do the things we do ultimately? Is it our world, is it our body, or is it something else? And again, we're going to take the world very seriously and the influences that we experience as people very seriously, and we're going to take the body very seriously. But we're going to also hone in primarily on the heart of worship. In Matthew 6:24, Jesus talks about the heart of worship, and he says, no one can serve two masters. You'll either love the one and hate the other, or be devoted to one and despise the other. And he's talking about the human heart. And in Romans 8:5-8, Paul speaks similar language, and he says the person who has their mind set on the desires of the flesh will pursue the desires of the flesh, and that the desires of the flesh are hostile to God by nature. But those who have their minds set on the desire of the Holy Spirit will pursue those desires of the Holy Spirit, and when we get our minds fixed on the desires of the Holy Spirit, it will produce life and peace. And as a Christian, my understanding of Scripture is that that the Holy Spirit resides in the believer and resurrects us so that we may believe. In Colossians 3:5, Paul is speaking again, and he is talking about the earthly nature, that part of us that we were prior to conversion. And he says, put off, therefore, and he mentions several things, but the last three things he mentions, evil desires and coveting, which is idolatry. And this word desire is a big word when it comes to the issue of motivation. And Paul is putting the word desire in the realm of worship. He's saying at the end of the day, if we are enslaved or mastered by an evil desire, that is a form of idolatry in our lives, and that we need to pay close attention to that which we want. Another passage that you may all be familiar with is Jesus said, where your treasure is, there your heart will be also. What you ultimately treasure as a human being will drive you and guide you. In Ephesians 4:22 through 24, it's Paul again, and he's talking about putting off the old self, which is being corrupted by deceitful desire, and to be made new in the attitude of your mind, and to put on the new self, which was created to be like God in true righteousness and holiness. And then in Galatians, he continues this line of thought by talking about the war that's being waged within the human being, specifically the Christian, where the spirit is desiring one thing and the flesh is desiring another. So one image that the scripture gives to us, and again, keep in mind, I'm painting with a very broad brush because I've got 30 minutes to talk about something that we could spend a week discussing. But here is one image that the Bible gives to us in terms of what's going on in our hearts. It's the root and fruit. Jeremiah 17, I want to read this. Thus says the Lord, cursed is the one who trusts in man and makes flesh his strength, whose heart turns away from the Lord. He is like a shrub in the desert and shall not see any good come. He shall dwell in the parched places of the wilderness, in an uninhabited salt land. But blessed is the one who trusts in the Lord, whose trust is the Lord. He is like a tree planted by water that sends out its roots by the stream and does not fear when heat comes. For its leaves remain green and is not anxious in the year of drought, for it does not cease to bear fruit. The heart is deceitful above all things and desperately sick. Who can understand it? I, the Lord, search the heart and examine the mind. It's a very diagnostic passage. And what Jeremiah is proposing here is that when we ultimately must place our final trust in self or someone else, that it produces something in the human soul. He says, especially for the Christian, that we become dying shrubs in the wilderness. It's a powerful picture of the inner workings of the soul. A person who is dying, and often when people are coming to me, I see a shrub. I see people struggling. They're struggling with things like paranoia and fear, relational conflict, strife and dissension, addictions like drunkenness, obsessions and compulsions, depression, anxiety, anger, and self-harm. And what Jeremiah is telling us here is those things ultimately, from a spiritual perspective, come from placing trust in a finite person, whether it's myself or someone else. And we understand and unpack this construct of trust in the realm of affections or desires, as well as in the realm of beliefs and cognitions. And from my perspective, even as a Christian, I have to wrestle with this every single day, that I have the pull of my own sinfulness. I have the pull of my own depravity that's always tempting me to take my own self as the final reference point, or to put too much trust in another person that creates terrible insecurity in me. And so I'm very, very familiar with the dynamic that Jeremiah is speaking of. But he also talks about another way of living, learning what it means. And we could be very trite in saying, trust the Lord. As a biblical counselor, if you ever came to me, you're not going to hear that trite comment come out of my mouth, because when people are in the throes of terrible psychological struggle, the most cruel thing I could say to them is just trust the Lord. But my worldview is, how do we get this person there? How can I be used as God's instrument to invite that person to trust the most trustworthy person that I know? And so the image that Jeremiah gives us is very different for the person who's walking with this abiding trust in an infinite being who loves us. And he says this person is like a tree that's planted by the water that sends out its roots by the stream, and its leaves remain green. And this picture here is not one where there's no trouble. It isn't anxious in a year of drought. So the idea that even when drought comes in our lives, whatever form that may be, learning lifelong lesson. I mean, I don't think we'll ever get to the end of what it means to trust God in this world. But with God's help and the guidance and empowering of the Holy Spirit, I do believe we can grow progressively through our struggles and through our joys to learn, what does it mean to trust in God when it seems like my entire life is nothing but one big drought. And it doesn't cease to bear fruit even in the midst of heat. And that's the hope that I give to many of my counselees, that your situation may not necessarily improve overnight. You may not walk through this depressive episode in a matter of days. This could take time. And even with good therapy of any kind, it can take time. But I have something that I can give to people that come to me, that even if the heat continues to bear down upon you, there's something in the spiritual life that says my circumstances do not have to change for me to be a person that continues to bear the glorious fruit of the Spirit. I can still have, in my own experience, love and joy and peace and patience and gentleness and faithfulness. And so biblical counseling primarily, and this may surprise you, isn't going to be most concerned about symptom relief. We want people to feel better, and I work with people to accomplish that end. But as I said earlier, the telos, the final end of my desire for people, is that through their suffering, they would discover the faithfulness of God in the struggle, that they would discover the beauties of the gospel in their struggle, that they would experience through my care for them the love of Christ as I genuinely step into their world and walk with them through the situation that they're facing. But Jeremiah also gives us something that's extremely diagnostic. He says, the heart is deceitful and beyond cure. Who can understand it? I've been a Christian most of my life, but I can stand before you and tell you that often my heart can deceive me to believe things that are not true. Or my heart can influence me and cause me to think things that are terrible and sinful. Because I'm still in this fallen place where I'm having to rest on the hope that God is committed to continuing to progressively transform me into the image of Christ, so that I more and more reflect Him in the way that I engage my world on a daily basis. So some of the biblical counseling limitations or weaknesses that I would put forth here is the misapplication of biblical truth. So anyone in this room could walk out of here tonight and take what I just said and abuse it in a way that would actually cause a lot of harm to an individual spiritually and psychologically. And I train a lot of interns, and one of the things that I'm very careful to teach them is we can't misapply biblical truth. We can't pull a passage out of context and proof text. We can't beat people over the head with Bible verses and say, read this verse, these two verses, and call me tomorrow morning. That cannot be our approach, or we're not practicing true, rich, authentic biblical care. Exercising poor hermeneutics and exegesis, proof texting, which I just mentioned. And I will say, if you look at our history, which goes back to formally, I believe biblical counseling began in the beginning when God counseled Adam and Eve on the path to life and death. But the formal movement of biblical counseling got its start in around 1970, and as any movement that is developing, people tended to err on the side of proof texting at times and misapplying the Bible and abusing the Bible. Assuming a polemical stance in counseling. I'm going to come to people, or people are going to come to me who may wrestle with God. They believe in God. They're coming to me because they know that's the approach I'm taking, but they may wrestle. They may be angry. They may struggle with particular aspects of the Bible. And it's not my job to take on a polemical stance and just drive them into the ground with what I believe and completely bulldoze what they believe. It's my job to step into that struggle with them and enter the tough questions with them, and with patience and love and kindness, consult the Bible and try to come to an answer that touches their heart. A lack of supervised experience during training. This, I would say, is a limit. So as a licensed counselor, before I could have my license, I had to go through 3,000 hours of supervised care, 1,500 face-to-face and 1,500 administrative. Right now, biblical counseling, I don't think has a supervisory model that comes close to that. I think that's a limit. I think that's something that my colleagues and I will definitely need to consider in the future. Multicultural applications. Something that excites me in terms of being a part of the Biblical Counseling Coalition is we are really branching out at an international level. Our ministry, the Association of Biblical Counselors, has an outreach in Zambia, Africa, where we have been able to come in to train hundreds of people in biblical counseling for some terrible suffering that we in America have a hard time understanding. It's the norm if you're a female to be raped in that culture. It is not unusual for many people in your family to be infected with HIV. There's a ton of witchcraft in this country. And so as we began to take our training material over there, we began to recognize very quickly that the multicultural stance was lacking. And it charged us to begin to rewrite the curriculum in such a way that it would be meaningful to the culture of the Zambians. And the biblical counseling movement as a whole is doing the same thing in many other countries. Biblical counseling, as I said, started formally in 1970 with a man by the name of J. Adams. And so it's a relatively young model in development. But the exciting thing, if you read the literature from 1970 to present day, you see profound development in our work. A much richer and robust model is forming, and it continues to form. And finally, something that we want to avoid in biblical counseling is reverting to a cookie-cutter approach. And I think as a counselor, we all have to be careful about this, but we don't want to just, every single person that walks into my office, I have basic presuppositions on human nature and who they are, but I'm dealing with an individual. And so I can't just come to that person with the exact same cookie-cutter approach as I did the person in the last hour struggling with the very same issue. And so as I look at biblical counseling, those are 7 limitations or weaknesses that I see, and thankfully, most of them, if not all of them, we're all cognizant in our culture of biblical counseling and working towards alleviating these limitations. Thank you.
Dr. Jeremy Lelek. Real quick, we're doing something different tonight. We would normally have both speakers present, then do a cross-examination. Tonight, we're going to actually do a case study from each presenter. Our next speaker, Dr. Lack, will be doing his case study immediately after his presentation. That said, Dr. Caleb Black is a licensed clinical psychologist, professor, author, and the director of the Psychotherapy Project, an associate professor of psychology, and the counseling practicum coordinator in the Department of Psychology at the University of Central Oklahoma. Dr. Black is the author or editor of 6 books on topics from critical thinking and pseudoscience to racism and sexism in early psychology to various kinds of psychopathology. He's also authored more than 45 scientific publications relating to the assessment and treatment of psychological problems such as obsessive compulsive disorder, Tourette syndrome, pediatric mood disorders, and post-traumatic stress. In addition, Dr. Black has presented nationwide and internationally at conferences on a variety of topics, is on the editorial board of scientific journals, and is a reviewer for both journals and granting agencies. Dr. Black's clinical interest in evidence-based practice developed while in graduate school for clinical psychology at Oklahoma State University and during his pre-doctoral internship in clinical child pediatric psychology at the University of Florida. He specializes in the treatment of children and adults with anxiety disorders and obsessive compulsive and related disorders such as chronic tics, Tourette syndrome, here we go, trichotillomania. Thank you, Zach. I was like, Zach, how do you say that? And excoriation. He consults for numerous businesses and is interviewed regularly by local, national, and international media outlets. Dr. Black also writes the Great Plains Skeptic column on the Skeptic Inc. network, as well as presenting about skepticism and critical thinking frequently. Currently, he is the director of the Psychotherapy Project, which aims to bring together non-religious persons seeking mental health treatment with secular, evidence-based providers. A native Oklahoman, we'll forgive him for that. Dr. Black grew up in the rural community of Mountain View, where his parents still reside and farm and ranch on land that has been owned by the family for close to 100 years. He currently resides in Edmond, Oklahoma with his beautiful wife and brilliant son on a wonderful old property called Free Thought Farm. Speaking to the topic of counseling, biblical and psychology, strengths and weaknesses, please welcome Dr. Caleb Black.
All right. Hello, everybody. First of all, I just wanted to apologize that you have to look at me. So if anyone needs to shut their eyes at any point, I understand. There's lots of glare off of this. You know, they didn't powder me up usually like they did. So I wanted to thank Ezra and the BBC and Magnolia and all of you for coming out. I think this is a fantastic thing that he's got going down here. It's great to sort of have these debates, and I think having them in this kind of an atmosphere is wonderful, because I don't know about any of you, but I personally like beer and alcohol. So I think that's a great combination of things. So I'm here today to basically talk about the flip side of what Jeremy spoke to. And I specifically am going to be talking about what we call evidence-based psychology. Evidence-based psychology. So what are the benefits? What are the weaknesses? Now, you may or may not know that healthcare in America sometimes costs a little bit of money. And mental health care costs a very large chunk of money each year. About $400 billion, it turns out. $200 billion of which is spent on direct client care, so paying people like myself and Jeremy and counselors and therapists, psychologists, to perform therapy, evaluations, and so on. That's a huge amount of money. I don't know about you guys, that's a little more than I make each year. Just a smidge, right? Several dozen decimal places. But we should know, if there's this much money being spent on something, we should know, is it being spent wisely or is it being spent poorly? Is it being spent what I would call ethically or unethically? And I want to just kind of start out with a little bit of an understanding of some terms, because a lot of times when you start talking about mental health, there's all these terms that start getting thrown around, and you may not know what these terms are because there's so many of them, and there's so many different kinds of mental health providers, and they're everywhere, and they're all advertising different kinds of services, and what all are they trying to say, and I don't even know, and who is this person? I don't know. There's lots of acronyms and things after people's names. And so what I want to specifically talk about tonight is something that actually encompasses all different kinds of mental health practice, whether you're a counselor or a psychologist or a marriage and family therapist or a school psychologist or whatever you happen to be. And that, what I'm going to talk about is going to be called evidence-based practice. Because usually when I start by saying I'm a psychologist, people usually have this sort of a response, which is, I don't know what that means. Do you sit on a couch and interpret dreams? Do you talk about my mother and how everyone hated her or hates me because of her, or what? And not so much, it turns out. People get really confused about these terms, but I want to kind of simplify it and start with an operational definition, kind of like what Jeremy did with biblical counseling. So I'm going to be talking about what's called evidence-based practice. Evidence-based practice, which is the integration of the best available research with clinical expertise in the context of patient characteristics, culture, and preferences. So what this basically means is, as an evidence-based practitioner, what I do is I use things that have been shown to work. Now, if I'm a psychiatrist who's a medical physician, then maybe I'm prescribing certain kinds of medications or doing specific kinds of surgeries. As a psychologist, I'm using particular kinds of therapies, particular kinds of diagnostic tools that have been demonstrated to be effective via well-controlled, client-focused trials. Meaning I'm not just saying, well, I think this will work. Why don't we just go with that? So evidence-based practice, as I'm going to be talking about it, is really more of a method of making decisions, right? A method of making decisions. And it's a decision about what's most likely to help this person with this problem at this point in their life. So in other words, it's not saying, I'm going to apply this particular thing to everyone that walks in, or here's the only way that change can happen for this person. It's saying, what's going to work for this person that's sitting right here in front of me that is a unique individual? And it isn't restricted, like I mentioned, to any particular kind of mental health clinician. It doesn't matter if you're a master's level or a doctoral level sort of mental health provider. You can do evidence-based practice. Because it's all about starting with your patient who's coming in and saying, I have a problem, I have a concern, I'm struggling with something. And then an evidence-based practitioner says, what's the best thing that we can do to achieve a particular kind of outcome? Typically something like improved quality of life, increased functioning, decreased symptomology, things like that. And as an evidence-based practitioner, what I ask myself is, what kind of level of evidence does this particular therapy have for this particular problem? Because it turns out there's lots of therapies out there that are bunk and are useless and don't do anything. And so for me, I have to ask myself, is what I'm going to be doing going to work with this person at a high probability rate? So what I look for is I look for those evidence-based practices. These are our green lights. These are, go forward with this. This is what we need to do. And these are the treatments that have been reliably been shown to cause improvements across various kinds of symptoms and functioning. So an evidence-based practice says, we know this works for this. We know that this particular technique works for this. That's what an evidence-based practitioner does. Now, that's not in any way, shape, or form the only kind of practice that's out there. We can have, for example, what we would call poorly studied practices, which are those treatments which have not been studied well enough to determine whether or not they work, or those things that have very conflicting evidence regarding whether or not they work. So maybe some research trials come out and show this works well for depression or generalized anxiety, And then we have some others that say, well, it doesn't really seem to do that. So that would be what we call a poorly studied practice. But then we also have our red lights, our stops, which are non-evidence-based practices. And these are those treatments that have been reliably shown not to cause improvement, or in some cases even to cause further problems and exacerbation of symptoms. So we've got these three levels of evidence. And I, as a practitioner, when I'm evaluating what someone does, which is something I do very regularly, as a professor, we train mental health clinicians, I supervise, I consult. I first look at what's the level of evidence for what it is that you're doing. Because it turns out therapy is not just this one thing and everybody does it the same way. Last time we counted, and it took them a while, there were some 400 to 500 distinct versions of psychotherapy being offered in the United States alone. That's a lot. That's a lot of different kinds of therapies. Now, only some of those, it turns out, actually work. So in psychology specifically, when we're talking about evidence-based practice, the whole purpose of evidence-based practice is actually to promote effective psychological practice and enhance the confidence of the public in terms of them being able to and willing to seek help for their problems. And does so by using what we call empirically supported principles, whether that's for therapy, assessment, evaluation, etc. And at this point, we have 60 plus good years of research on psychology in the terms of therapy. We've got about 100 in terms of psychology in general, but in terms of therapy, we've got about 6 decades of research, and the research at this point is very, very clear. Psychology works, psychotherapy works, but not all psychotherapies are built the same and work the same. That being said, and we'll see some examples of that in just a minute, there is, again, this huge body of research out there now. We're talking thousands and thousands upon thousands of journal articles that have been peer-reviewed and published in various sources showing that certain therapies are safe and effective for children, for adolescents, for adults, for elders, for a wide range of problems, for more enduring than medications. So in other words, you take medication, it turns out for certain problems, when you stop taking your medication, it stops working. Good, effective therapies, like the ones I'm going to talk about, they keep working after that because they're changing how it is that you respond to your environment. They're changing how it is you respond to your external environment and your internal environment, to your thoughts and to people around you. And we know that therapy pays for itself. Good therapy pays for itself because it offsets medical costs, it improves quality of life. You see increased productivity across individuals who get that. And here's some examples of commonly used evidence-based practices in psychology. So these are terms that when you hear those, these are practitioners who are doing what we would consider to be gold standard level practice. Things like applied behavioral analysis, which most people, if they are familiar with that, know about it in terms of being used with autism, but it actually can be used with anybody. The behavioral and the cognitive behavioral therapies, which are my specialties. Motivational interviewing, which is primarily used to help folks who are struggling with different kinds of substance abuse. Interpersonal therapy, which has mostly been well established in the treatment of depression for adolescents and adults. And then for couples therapy, we have a few different things that work really well, but one that's called emotionally focused therapy, and that's probably the most well-studied model out there. So what do these various kinds of evidence-based practices work for? Well, a lot. The depressive disorders, anxiety and fear-based problems, eating disorders like anorexia, bulimia, post-trauma reactions, whether that's immediate sort of acute stress reactions or post-traumatic stress disorder, oppositional behavior in children, chronic insomnia and sleep problems, improving functioning of folks who have autism, improving functioning within families and within marriages, decreasing substance use, getting rid of bedwetting. What? You can therapize your way out of a wet bed? Yes, it turns out, and very quickly and effectively. So if anyone has that problem, see me afterwards. My rates are reasonable. It's okay. Low self-esteem, a lack of assertiveness, having anger issues and chronic violent behavior, chronic pain, getting people to adhere to medication, having sexual dysfunctions, and this is not in any way the full list. We have very well studied, very effective treatments for all of these and many more problem areas in life. Now, to me, that's a given that you should do those things, right? If you go to your physician and he says, well, we've got this thing that works for your problem, or we've got these other things that we know don't work for your problem, which one you want? I mean, who's going to be like, you know what, I'm gonna gamble. I'm taking that gamble. We're going to see what happens. No, we all say, well, I want the thing that works. Duh. Like, that makes no sense that I would take the thing that doesn't work. But it turns out there's tons and tons of therapies out there that are the not working, the don't working things. And unfortunately, a lot of these are more of what people think of when they think of therapy. So the sort of classical psychoanalytic therapies of Freud and Jung and Adler, for example, they don't have support showing that they actually cause good change and positive change for people who are experiencing mental health problems. Attachment-based therapies, of which there are many, many out there now, they don't really show to work. Energy therapies, like the most common one of those are the tappers. I don't know if any of you guys are familiar with these people, but these are people who, you'll have a trauma, they'll come in and they'll say, well, you take your hands and you tap certain points on your body while you're saying certain things, and that'll make all your problems go away. It's psychological acupuncture is what they often call it. And it doesn't work out, it turns any better than regular acupuncture, which also doesn't work out, it turns. The play therapies, there's not really research supporting the vast majority of what are considered play therapies. Sand tray therapies or art and music therapies, more of what we would call experiential therapies, don't really have support. Neuro-linguistic programming, which was kind of big in the 80s, where if I just say certain words, then that will change the way that you think and act. And it's like, nah, that doesn't really work. That's called magic. Doesn't work too well, it turns out. Harry Potter, not a documentary. But there's lots of this out there. Lots of these non-evidence-based practices out there. So our current ethical codes for the American Psychological Association, or the APA, the American Counseling Association, or the ACA, actually both stress the use of current best evidence in determining what one does in therapy. So the APA says psychologists' work is based upon established scientific and professional knowledge of the discipline. The ACA says counselors have a responsibility to the public to engage in counseling practices that are based on rigorous research. And so, to me, if you're going to be practicing ethically as a mental health professional, then you need to be using evidence-based practice. If you're not using evidence-based practice, to me, you are practicing unethically, because we have things that work. We know that they work. Why would I not use those things? And the boards of the APA and the ACA seem to agree with that. But, and this is the tricky problem, sorting out what is actually evidence-based versus non-evidence-based is tough. And it's tough not just for clients, but also for practitioners. Because many of our practitioners don't receive a huge amount of effective training in this. And this is why mental health clinicians who use evidence-based practice rely extraordinarily heavily on valid, reliable research studies. Because I can't just bring somebody in, treat them, see that they get better, and say, my treatment worked. Now, it may seem like I can, because they got better. Somebody got better, they came to me, they got better. Well, what the hell are you talking about? Of course that didn't work. Turns out, no. It turns out that research design matters, because there are numerous reasons why that person could have gotten better. And so we can't just ask, does this treatment work? I can't just say, does a person that comes to see me versus a person that comes to see you get better? We have to say, does the treatment work better than a placebo? Meaning that if they receive something with no active treatment in it, do they get better? And we have to ask, would this condition naturally improve over time even with no intervention? And this is the problem of what we call regression to the mean. Because it turns out that most of us who have mental health problems at some point in our life are not going to have those our entire life. Having a depressive episode, for example. 90% of people who have a depressive episode within 1 year will no longer qualify for a diagnosis of major depressive disorder. So if I have somebody come in the middle of a depressive crisis, and I treat them for a year and they get better, I can't be like, look at me, I'm amazing. Because they could have just went and talked to a statue for the last year and still received the same results. You don't know for sure. And that's why we have to have good research in order to guide what it is that we do as clinicians. And the best way to do this is through what we call randomized, placebo-controlled, double-blind procedures, which is a very long term. And it's even a long acronym. I couldn't even come up with a decent acronym for the damn thing, right? It's just like, here's your acronym. It's as long as most words. But what this is the way that we're able to really determine, does any kind of treatment work? Not just in psychology, but in medicine. Does any kind of treatment work? And it's these kind of high-quality clinical trials that we, as evidence-based practitioners, have to rely on in order to determine if something is what we call an evidence-based treatment. So to give you an idea of kind of what this looks like, if I'm looking at one of these trials in action, first, I take a bunch of people with a particular problem, obsessive-compulsive disorder, major depressive disorder, whatever, and I divide them into 2 treatment arms. The treatment, which means they get the active thing that we're trying to test, and the control, which means they get a placebo. So that would be, maybe they meet with a therapist on a weekly basis, but I just reflect what it is that they're talking about, and I just ask about how their week's going, and I don't really train them in any new sort of skills. All right. And the participants don't know which treatment arm they're in. So in other words, they are blinded to their participation. Right? So they don't know if they're getting a placebo versus an active treatment. And the people evaluating the outcome data are also blinded, meaning they don't know, when they're looking at the results, who was in which arm. And that's what we call a double-blinded study. And it's in this sort of way that we reduce our biases that we all naturally have as human beings. Because if I'm doing something, I want it to work, right? I mean, if I developed a therapy and then I tested, I'm not going to sit back and be like, I really hope this fails, because I do not like myself at all. Right? No, you're like, I developed this, I want this to work. But in order to assess whether or not it actually does, we have to have a double-blinded trial. And this is really the gold standard in evidence-based psychology. This is how we know whether or not something actually works. All right? It controls for placebos, it controls for biases. The way that they're set up controls for things like regression to the mean. So in other words, just naturally getting better. I'll give you a good example of why we need that. The most popular kind of treatment here in the United States for substance use problems is a 12-step model-based treatment. Now the 12-step model, many people swear by it, but all of our controlled research that we have shows that it doesn't work any better than doing nothing at all. So in other words, you take 100 people and you say, go to AA for a year. And you take another 100 people and you say, do whatever you want. And we check with them a year later, equal percentages of those people in both groups are going to be having non-problematic levels of drinking, for example. So it works, but it doesn't work any better than just living your life, it turns out. And we have to have those sort of pieces of information to be able to say, am I doing something that's effective? Is what we're doing actually effective or not? Now, evidence-based practice certainly does have some weaknesses to it, all right? And the weakness is that, one, not every potential human problem has a corresponding evidence-based treatment. Sometimes people come into therapy and they have what I refer to as CLD, which is crazy life disorder. And I can't turn around and go to, oh, there's the CLD manual. There we go. Oh, yeah, it's your particular CLD, right? Oh, yes, you started at age 2 being abused. And yes, you started having, very problematic relationships with your peers at age 3. Yes, it's all right. Here's my manual. No, we don't have a corresponding evidence-based practice for every single thing that somebody could come in with. All right, so that's a weakness. We also know that not all people will be treatment responders. All right, for example, the case that we're going to talk about is going to be a case of someone who has obsessive compulsive disorder. We have a great treatment for obsessive compulsive disorder, but we know that not everybody's going to get better still. Right? There's still going to be a small percentage of people that don't get better. So this could be because of a lack of social support, so they don't have a good support network in the home. This could be that they don't themselves follow through on treatment assignments. This could be maybe they can't access treatment. They don't have money, or there aren't any clinicians that are trained in a particular treatment in their area. So there certainly are some weaknesses to evidence-based practice. One of the big ones is actually this last one, which is lack of access to well-trained clinicians. The vast majority of training programs out there don't focus on evidence-based practice. The vast majority, let me say it again, of mental health practitioners out there have not been trained in the graduate programs on evidence-based practice, which means that you guys, not you particularly, I'm not like looking at you like, oh, diagnosis. But you all, the public, need to be aware of that so that you can be on the lookout for who should I go to. All right, so those are some weaknesses. And then you guys heard a lot about biblical counseling already from Jeremy. This was the definition that I was able to find that had a kind of a nice, succinct definition. And biblical counseling is the process where the Bible, God's word, is related individually to a person or persons who are struggling under the weight of personal sin and or the difficulties with suffering, so that he or she might genuinely change in the inner person to be pleasing to God. And I don't think that's too different from what you had talked about, Jeremy. There's some differences from your definition. But in my kind of review, that seemed to incorporate most of the aspects that biblical counseling had. So I thought it might be nice to just kind of have a one screen, from my perspective, what I see in the differences between evidence-based psychology and practice versus biblical counseling. So in evidence-based psychology, so for example, me, I'm an atheist. All right, I don't believe in any particular religion. I have a secular, humanistic worldview that's naturalist. And yet, I am somehow able to work with people from all sorts of backgrounds and religious faiths. I treat regularly Christians, non-theists, Muslims, people who are Jewish, Hindus, the whole sort of variety. And we can do that, where people who have any sort of problem and any sort of faith can still get good evidence-based care. I'm actually chairing a presentation at a national conference in San Diego in November, where it's myself and a Christian psychologist, a Jewish psychologist, a Muslim psychologist, and a secular humanist chaplain who's also a psychologist, are all discussing evidence-based care for these different groups. So evidence-based psychology, you can be used with people of any faith or no faith. Based on my understanding of biblical counseling, you're really only being able to talk about treating certain types of Christians, not even necessarily Christians as a whole. So, will a Catholic go to biblical counseling, for example? Maybe, maybe not, because they might have a very different worldview. What about somebody who comes from a highly literalist versus a more liberal theology approach? Biblical counseling may or may not work for some folks. Evidence-based psychology is based on the research that shows that certain therapies work for certain problems. And to me, that's crucial. It's not that all therapy works for all problems. It's certain therapies we know work for certain problems. Biblical counseling is based on the belief that the Bible is the end-all, be-all of knowledge, and that contains sort of our operating manual for the human experience, which we could argue about that in a whole other thing. But I would say that our knowledge base scientifically has shown that there's some things in there that are just not that accurate. Evidence-based psychology is also constantly improving and changing. And it does so via new evidence. It does so just like all science does, through testing our ideas, saying, does this work? Is this accurate? And then we put that to the test to see, am I on the right track? Biblical counseling, on the other hand, can be constantly changing, but it depends upon who's doing a particular interpretation of a particular passage. And as I think we're probably all aware in this room, there's only one denomination of Christianity, right? Right? Did I miss that memo? No, there are many, many, many. I mean, we probably have 10 plus denominations of Christianity here right now. How are all those people going to be able to agree upon a particular passage in the Bible and interpret it? It's going to depend upon the deliverer, not necessarily the source. And then evidence-based psychology is delivered via licensed mental health professionals who have specific training, who have engaged in specific kinds of supervised experience, education, have taken and passed certain kinds of licensure exams, and so on. Biblical counseling, literally anyone out there in the world can decide to call themselves a biblical counselor. There's no sort of standard licensure for that. There's no training requirements to be able to call yourself that. It's very kind of open to whoever. Now, if you go set up shop somewhere and you say, I'm a psychologist, I'm going to start seeing people, you're going to get a visit from the police because you are having to be licensed and had a particular kind of training to be able to show that you are competent to do that. Just like I couldn't go set up a surgery booth down at the stockyards and be like, come on in. What's your problem? I know roughly where that is. Give me a knife, right? Like, no, that's not going to work. So I see some very, very large differences then between evidence-based psychology and biblical counseling. Now, in conclusion today, we have more effective therapies for a wider variety of problems than ever before in human history. But, unfortunately, we still have many practitioners out there that do not use evidence-based practice. And so that means that you all, as consumers, need to be educated about what to look for. Who's doing something in particular? Does it actually work or not? And you can't just rely on that person telling you, right? That's like relying on the used car salesman, right? It's beautiful, it runs wonderfully. And you go, I'm gonna check that out myself. Do the same thing with therapists. Because evidence-based practice really protects therapists and it protects clients by ensuring that they are receiving the top-notch, best standards of care for whatever their particular problems are. It's good for everybody, in other words. So, we even knew this, it turns out, 2,500 plus years ago with Hippocrates, or as Bill and Ted would say, Hippocrates. There are, in fact, two things, science and opinion. The former begets knowledge, the latter, ignorance. And that's my part of that presentation. So thank you.
Dr. Kayla Black. So what we'll do now is, yes, Dr. Black will be given 15 minutes to do a case study that he will show the slides on. After that, Dr. Luck will do the same. So if you'd like to come back, sir.
All right, so because we're not talking about something super abstract, we're actually talking about something that happens in the real world every day. Ezra and Jeremy had the idea to come up with a case presentation where each of us presents on the same person, the same individual, and say, here's how I would treat it, here's how you would treat it. And so that's what we'll be doing now. So we'll be using the exact same case. So I'm going to go over the case, and then I'm going to talk about how I would treat it, and then Jeremy will come up and talk about how he would treat that. And then I believe we're going to arm wrestle. Is that right, Jeremy? Oh, where'd he go? Knives? I didn't know how you do it in Texas, so I didn't know. Guns. There we go. There we go. Why am I not surprised by that answer? So, all right. So here's our case. All right. So this is a pseudonym Mark. This is a case that we made up and agreed on. So this is a 15-year-old male who's referred to the clinic. He had been previously diagnosed with obsessive compulsive disorder. So some background on Mark. He comes from an evangelical Christian household. The church is really a major center of family life and free time for he and his family. He comes from an intact biological family. He has one older sister, so just one sibling. No reported major concerns about family conflict or anything like that. So the reason that Mark would be able to be diagnosed with obsessive compulsive disorder is that he reports having what we call obsessions, which are intrusive, unwanted thoughts, dozens to hundreds of times per day. His obsessions in particular revolve around him drawing, and this is either accidentally or on purpose, the symbol of an upside down cross. So he has the idea that I'm going to do that. Now, that's a problem because he gets very upset and anxious whenever he has that thought. All right? He becomes very upset and anxious whenever he has that thought because he thinks, well, that means that other people are going to go to hell. If they see that, they'll become a Satanist. That shows that I'm blaspheming. That's against my religious beliefs. So he becomes very, very upset with that. And again, this isn't like once a day. We're talking dozens to hundreds of times per day. And each time that thought comes, he gets very anxious, very upset, and then he engages in something to try and decrease that anxiety. Right? So for him, he engages in what we would call compulsions, or compulsive behaviors and acts, praying for forgiveness, asking his parents if he's going to hell, and then an avoidance compulsion of writing. So he doesn't write anything at all where anybody else might see him. Now, not only is he having all this anxiety from having these obsessions, he starts withdrawing from activities with friends and family because it's embarrassing. Right? He has this thought, he has to ask a question. He's also been refusing to do work at school because he can't write in public. He's afraid that he's going to make an upside-down cross. This has resulted in poor grades, high amounts of conflict with his teachers, and he's not sure if he's going to be able to pass these various classes. All right? So that's Mark. That's kind of what Mark looks like. He comes into the clinic and he says, help. And his parents say, please help. And we say, okay, what are we going to do then? All right. Now he comes into my clinic. This is what we do. First, I look at the research literature. And I look at the research literature and I say, what do we know works for obsessive compulsive disorder in youth? And it turns out we have this wonderful treatment, cognitive behavioral therapy treatment, that works fantastically for this problem. I see tons and tons of research studies showing this. It shows that it's superior to medication alone, and it focuses on what we call exposure and response prevention, EXRP. And the research literature has shown effect sizes of anywhere from a 1.16 up to a 1.72, which for those of you who don't do statistics, like everyone, that means that somewhere between 88 and 95% of people in these controlled clinical trials show improvements. That's amazing. That's a huge, huge hit rate, right? I also look at the research literature and I see that there's a low relapse rate, meaning most people who go through treatment and are treatment responders don't then continue to get worse. They don't have relapse problems. But I see that about a quarter of people actually will drop out prior to completion of treatment. So a relatively high dropout rate. So I get all that information from my research literature. Right? This isn't me just, thinking in my brain. This is me looking at the work of literally hundreds and hundreds and hundreds of researchers over the last 35 years. And so, based on that, I say, well, that seems to be the most effective thing that we have out there to treat OCD. So let's talk about what cognitive behavioral therapy does for OCD then. Most of our cognitive behavioral therapies focus on what we call a bidirectional view of behavior and cognition, meaning my behavior impacts my emotions, my cognitions impacts my emotions. What I do impacts my emotions, how I think impacts my emotions. And it turns out those then all impact each other as well. So my thoughts influence my behavior influences my thoughts, and my emotions influence both of those. So from a cognitive behavioral perspective, what I have to do is I have to look at where can I intervene. Can I intervene at the level of behavior? Can I intervene at the level of cognitions or thoughts in order to effectively change that emotional state? So in CBT, what we then look at is we see that obsessions tend to arise from dysfunctional beliefs that a person has. So, in other words, they believe something that it's inaccurate based on reality. And those dysfunctional beliefs then cause intrusive, unwanted thoughts, which are actually very normal. all right? Everyone in here has had an intrusive, unwanted thought at some point, right? And those are the sort of thing where you're just, let's say you're just walking down the street, you see a cute little puppy, and you just have this flash of you just like kicking that puppy out into the street. And you think, dear Lord, that is terrible. I would never do that. And you give the puppy a little pet. The puppy doesn't know how close it came, right? You give the puppy a little pet, and then you go on your way. And you don't worry about it. But somebody who has OCD takes that thought, which all of us would have, and says, what does that mean about me? Oh my God, I'm a terrible person. That's horrible. Oh, that's unacceptable. I cannot have that kind of thought. I shouldn't have that kind of thought, which then causes you to feel distressed, right? Like, I have a thought like that, I do this. Brains are weird. And then I go on about my business, right? And I just do that, and it's fine. So I don't have OCD. But what this distress actually causes one to do is they try and escape and reduce it. All of us do this naturally, right? If you are experiencing distress, you're upset, you're sad, you're afraid, what do? You get away from the thing that's causing that, right? If I just reached back here and started throwing out tarantulas into I'm not going to do it. Some of you are already worried, I'm not going to do it. But if I started doing that, many of you would then start running out the doors or through the windows or something like that, depending on your level of fear, because you're trying to reduce your anxiety. But what happens when you do that is actually it reinforces those escape behaviors, which means that you start thinking that my thought, my dysfunctional belief, actually was useful and good, and it was right because I was afraid, and now I'm not anymore because I escaped. But it turns out that just makes things worse. So for Mark, for example, and I did all these illustrations myself, don't be impressed. So Mark, as a little baby, was raised in a fundamentalist evangelical religious household. Due to this upbringing, he began to develop a belief system that Satan could put thoughts into your head in order to try and make you do or think things that were sinful, perform evil actions. Right? Then one day, he was doodling on a sheet of paper and just by chance happened to draw 2 lines, 1 line slightly below level. And that's the shape of an upside down T. Now, this didn't mean anything to him at the time, right? He's just a little kiddo doodling, drawing, do. But his mother came by. She saw what he had drawn, tore the paper away from him, became very upset, yelled about the blasphemous thing that he had done, and then that made him feel upset. If you're a kid and your parent gets upset about something, you think, oh, I should probably be upset too. His mother then proceeds to tell him that he has to pray for forgiveness so that he won't go to hell. After he prays for forgiveness, he feels much better, right? He feels better. Oh, okay, now I'm not going to hell, which is great, right? And now I don't feel bad. The problem with that sort of thing is that for those people who are biologically predisposed to have things like anxiety disorders and obsessive-compulsive disorder, that's not where the cycle ends. Because the next time he starts to draw, or maybe he sees a notebook that's been turned upside down and it has a T on it, that's going to start making him upset and distressed because, oh, that symbol, that's not good. That's not good at all. That's going to cause me to have this intrusive thought that that's the devil at play. That's the devil at work here trying to cause me to die, go to hell, as opposed to do what I want to do with my life. So in other words, I give a threatening appraisal, which makes me feel very upset. And then I think, oh, what can I do? What can I do? Last time I prayed. Mom made me pray. I'm going to start praying. Hey, that anxiety's going to go down. But it's just going to go down temporarily. Because then what's going to happen is next time you see that trigger again, it's going to get equally problematic. And you're going to feel distressed again. And you're going to do the same thing. And we see the shark tooth effect where people get upset and then they get better. And then they get upset and they get better. And pretty soon it's all very high shark teeth. And those thoughts are coming sometimes multiple times a minute, but at least dozens of times a day. So he comes into me, and knowing that this is what's going on with him, I outline, here's our treatment. Typically, we're talking 10 to 16 sessions. Since he's a child, we would include the parents and the children in all aspects of treatment. We'd probably also reach out to his teachers. And there are 3 primary components that we would do. We would do education. We would do education about what the parents are doing that might be reinforcing this, as well as about just kind of how OCD operates. And then you start doing exposure and response prevention with some cognitive strategies, which we'll talk about. Right? So first, I'm going to assess what's going on. I'm going to look at cultural factors that might be in play. So for example, he comes from this religious household. That helps to explain maybe why he's having these kinds of thoughts. We look at what we call level of family accommodation, which means that I look at, what's the family doing to help maintain this, right? What's going on in terms of those behaviors? And we try and keep track of our progress to see who's doing what. Then we move into our educational phase. We talk about here's what causes OCD. Here's how it's effectively treated. And then we move into building what we call a fear ladder. And a fear ladder is basically the things that I don't want to do, the things that are going to cause me anxiety and distress. And we start figuring out how is Mark, this 15-year-old, how is he going to be reinforced and rewarded for completing tasks in therapy? Because that's a big thing that you want to do, is try and change those behaviors. So here's a fear ladder for somebody like Mark. Right? These are all the things that he avoids doing. All right? And here's how much distress each one of those causes him from a 0 to 100 scale. So drawing an upside-down cross in front of his parents, he says, I could not do that because then I would be condemning my parents to hell, right? It's less in front of his sister, it's less in front of his friends, it's less in front of his teacher, it's less in front of somebody he doesn't know. Just seeing an upside-down cross makes me a little nervous, but if I'm the only one who sees it, no one else is going to hell, and so I'll just pray for forgiveness and be okay. So we construct this kind of ladder, right? These ladder of feared situations. And then what we start doing is what we call exposure and response prevention. And exposure and response prevention is the key ingredient in all evidence-based anxiety treatments. If there's a treatment that works, it works because of this exposure and response prevention component. And so what this is the person does the thing that they fear, right? They're exposed to the thing that they fear, but then they're not allowed to escape, right? They're not allowed to do what their anxiety and their fear wants them to do. So you prevent that anxiety-based response. And what we do is we start with lower items on the fear ladder and we work our way up to the tougher things. And here's a picture of what it looks like, which isn't quite as exciting as maybe what some of you were thinking. But this is a graph of what exposure and response prevention looks like, where what happens is when I start an exposure, my anxiety goes up because I'm giving you the thing that you're afraid of, right? So if you're afraid of a snake, I'd show you a picture of a snake, right? For Mark, we would start with just maybe seeing a picture of an upside-down cross, right? His anxiety is going to go up. And they think that if I don't escape, if I don't avoid, if I don't do my compulsion, then my anxiety is going to keep going up, my distress is going to keep going up, my heart's going to explode, and I'm going to die. And that's what people with anxiety think. That's how they think. That's just what's going to happen. My heart would literally, cartoon style, explode out of my chest, and it's going to be all over your office, and it's your fault, and you killed me. But it turns out you can only get so anxious, and not even to heart-chest explosion level anxious, right? So you get anxious, but then your anxiety levels off. And then, this is what we know happens. The longer you stay in the presence of that feared stimulus, the longer your anxiety will go down. And it'll go down and down and down. So what we see then is that the more that we do this over and over again, the less and less fear you start showing to these particular kinds of stimuli. So I show you a snake, if you're afraid of snakes, and I don't just go ha, ha, because then you'll just be ah. I say, ha, and then I just leave it there. And you go, ah. And then it turns out you can't stay anxious forever, and eventually your anxiety goes down, and I've got the snake in front of you, and you're just kind of okay, it's boring, it's fine. And so that's what we do with Mark. So we explain treatment, we develop this fear hierarchy, we set up a reward program, and then we start doing exposures. We begin at the bottom of the ladder with him just seeing me as a therapist holding pictures of an upside-down cross. All right, here we go. We're going to look at it. And he has to look at that cross that's upside down, that's triggering these obsessive thoughts, until his anxiety goes down. And we do that until he no longer feels the need to engage in these compulsions. And it sounds kind of crazy to people when you start talking about it. Particularly people have anxiety and they're like, I want to feel better and you're telling me that you're going to make me feel worse on purpose? A lot. That is the opposite of what I wanted. But it works beautifully, and we know this from, at this point, 60 plus years of research. So between the sessions, Mark and his parents would have to do the same sort of exposure activity. All right, they're extinguishing his fear response to that stimuli. The next session, we move up to the next rung of the ladder. Homework, do the same thing. Next session, next rung of the ladder. Homework, do the same thing. And you keep moving up that ladder until all things are conquered. And then, and this is the really fun part, you have to engage in what we call overlearning, which is we then do things that you probably wouldn't encounter in everyday life, so that if you do encounter something in everyday life, it's no big deal. So with Mark, we would do things like he would have a notebook that has a cross on it, and he would just have to purposefully carry it around upside down at school, because that's something he's terrified about, right? Is that people are gonna see this and they're gonna think that I'm going to hell, or that's gonna make them go to hell. He would drive around town with an upside down cross taped to the window of his parents' car, because he's afraid that, everything terrible is going to happen. Like, there's going to be this rash of Satanism in the town, right? He would draw upside down crosses while sitting in a church. And the whole purpose of all of this is to overlearn that fear response, to extinguish that fear response. All right. Then you move to sessions that are spaced further and further apart. And what you've done at this point is you've taught them that here's the tools that you need. Here's the tools you need. Go forward. You do that. Come back if you need help, but you don't have to come back, because now you've got these tools. And that's how we would treat Mark. All right. Thank you.
Dr. Caleb Leck. Dr. Lelek?
You're fine.
Same patient, same case.
All right, you may have to help me get this going here. What do I need to do? Let's see. Oh, yeah. Here's mine. Thank you, sir. Fifteen minutes or so. Okay. All right. Let me just start by saying, as a biblical counselor, I can actually appreciate much of what Dr. Lack just presented. As was cited in the initial definition of biblical counseling, we are not opposed to psychological research and would want to draw from that. The problem is psychological research is done from a materialist worldview, and in the world of psychology, there's a lot of humanism even that's assumed in some of the research. But overall, I would totally embrace research that's going to help me serve people better. I do also have to say about that last slide with Hippocrates, I found it ironic and interesting that when making the point that opinions only breed ignorance, that a philosopher's opinion was used to make that point. So I don't know what to do with that one. Also, as far as research goes, there is research out there, very good research, that shows that lay counseling within the context of the local church is very effective. And so it's not as though, again, biblical counselors don't want to embrace something like that. We're studying, is what we're doing effective with people? And finally, on the case study here, everything that Dr. Lack just presented would relieve symptomology as it regards a doodle on a piece of paper. There's no question about that. Most of the time, that works. However, nothing that was presented there would do anything to help Mark in his construct of God. Because as long as his construct of God is this beast in the sky that's ready to send us all to hell for drawing an upside-down T, then I think cognitively, Mark needs help there. Because he may get over his symptomology with the upside-down cross, but we're leaving him with a gaping hole where further anxiety is going to torment him for the rest of his life, because the reference point of his life, God, is something that will breed anxiety for the rest of his life. Also, when we talk about ethics, we're also called to ethically respect the values of the client. And so I would struggle if the value of my client was to not blaspheme, to encourage them to do things that he would deem blasphemous. Just a thought. So here is what I would do generally to help Mark. Won't spend a ton of time here, but we saw this in the last presentation, and one of the things that I would do early on is I would assess the physical and the social aspects of what's going on with Mark, just as Dr. Lack presented himself. I would do a rigorous assessment to try to get a deeper understanding of him on a medical level. I would send him to a psychiatrist, send him to a medical doctor maybe, to get a physical, just to make sure that everything's okay with him at a biological level. And I would want to know his story, his upbringing. Something's going on here where he's been influenced by his parents in such a way that it looks like it's creating some problems for him. So we would do a lot of work here, and the intervention that we're about to look at might come, I don't know when it would come in the process. It wouldn't be first session or second, but after we did these assessments, we would begin to apply some methodology and intervention. Remember the root and fruit that we looked at in the last presentation. Something's going on in Mark's affections and his desires, as well as his beliefs and his cognitions, where he's placing his faith and his trust in himself or in the ideas of his parents. And what's going on is it's creating these symptomologies that were cited in the case study: fear of condemnation, intense anxiety, compulsive praying, compulsive need to reassure for reassurance from parents.
I can't see your presentation.
Oh. Thank you, brother. Sorry about that, guys. Fear of condemnation, intense anxiety, compulsive praying, compulsive need for reassurance from parents. He avoids writing anything at this point for fear that he'll slip up again. Withdrawal from friends and family, refusing to do work at school, and conflict with teachers. So those are that's the thorny stuff in his life that's being produced as a result of what's going on within his heart in the realm of affections, desires, beliefs, and cognitions. So one of the things that I would do is I want to hear Mark's heart. What's going on in his circumstances? What is he thinking and believing about his circumstances? And how are they conditioning his responses? Regarding his circumstances, I want to know, how does Mark respond emotionally to his circumstances, and how do these feelings reveal what he values and treasures, moving into the realm of desires and feelings? And then volitionally, what is he doing? What choices is Mark making in response to his circumstances? What do these choices reveal about his core commitments in life? And then I also want to look at the way he is relating and experiencing other people. How do the beliefs of others shape his own beliefs? As far as his affections, how do others influence his emotions? How do the value systems of others influence what he wants, what he treasures, what he lives for in his life? And how does his commitments reflect the culture around him? What does his choices indicate about his commitments? And then I want to know what he's thinking about himself. What does he think God thinks about him? And in this realm of desire and feelings, I want to know, how does Mark feel about himself? And what is his ideal me that he's trying to achieve? And volitionally, how does his actions reflect his beliefs and values about himself? And then finally, the triune God. What does he believe about God? Functional and theoretical. So people in the Christian community have functional belief about God, so I can go to church and I can say Jesus loves me, I can say Jesus is forgiving, or that's theoretical. That's what I say I believe, but functionally, when the rubber meets the road, is that how I respond in life? So I want to check out, what do you say you believe, and then functionally, what do you actually believe based on what we're seeing in your response? And his affections, the desires and feelings, how does Mark feel towards God? And what does he wish God would do for him? And then finally, does Mark's life reflect faith in the gospel and a commitment to God? And so here's some things that I would observe for Mark. Regarding his circumstances and his thoughts and beliefs, Mark has inadvertently drew a symbol for an upside-down cross at school, and he believes because he's done that, he's committed an act of blasphemy, and this has threatened his relationship with the Lord, to the point that he is actually fearing hell. His desires and feelings, Mark is experiencing an intense anxiety. He seems to desire acceptance by God, but on his own terms, and we'll talk about that in a moment. He is desiring perfection and approval by God, and probably his parents as well. And then volitionally, Mark is engaging in compulsive behavior such as endless prayer, avoidance of writing, and seeking reassurance from parents. As it regards others, Mark is highly influenced by his parents' beliefs about God and seems to embrace a legalistic approach to his faith. If I can just live my life without doing the really bad thing, I'll be okay. Affection and desires and feelings, his parents' religiosity tends to reinforce Mark's intense struggle with fear. Their emphasis on prayer actually exacerbates his obsessions because the person that he's praying to is a very scary person. Volition, will, and choice. Mark is reflecting the commitments of his evangelical family and culture. It sounds like this commitment to live up to a certain standard so that you can be what they would call a good Christian person. Regarding himself, Mark thinks he is an evil person in danger of hell. He feels he's condemned, or in danger of being condemned if he doesn't continue these rituals in which he has found a false hope. Mark, though not realizing it yet, believes he should elicit perfection as a person. That's his desire, perfection, acceptance by God through my own perfection. And then his actions reinforce the illusion that he has the capacity to redeem himself. I mean, this obsessive ritual that he's in is a religious ritual that has nothing to do whatsoever with the Christianity and the gospel that's presented in the scriptures. And then regarding the triune God, Mark believes that God is angry at him and wants to condemn him. Mark is terrified by God's judgment and just longs for God to forgive. And Mark's life, to me, does not seem to reflect trust in the finished work of the gospel of Jesus Christ. So somewhere in the process, after I get my mind around what's going on with Mark, we might talk about the tree and the shrub just to illustrate to him. Here, if you're looking at your life through a biblical lens, here's a picture that might capture to a degree what you're experiencing right now. But homework for him at some point might be to read the following scriptures and write out what they reveal. So I'm pointing him back. He is a person of faith, and he has some cognitions that he believes reflect Scripture, but we need to go to Scripture and see what's actually going on. Reshaping Mark's mind with divine truth. During the following session, I'll have Mark bring what he's gleaned from these passages back, and he'll read them out loud, and he and I will talk through that. And I will assist him to clarify any meanings of passages and begin collaborating with Mark to formulate new thoughts that correlate with the assigned scriptures. And when I say help him collaborate and formulate meanings, it's not just my opinion, it's the opinions of scholar upon scholar upon scholar upon scholar for hundreds of years that have come to these same conclusions as they've studied these very same passages. And then I would want to invite the parents into the process and provide instruction and brief training and get their thoughts also on what they think about their son's struggle, but try to engender in them, if you really want to be instruments of grace in your son's life, I want you to become an advocate for him and reinforce much of what we're doing here in the counseling session. If, obviously, Mark is open to that. I would be very sensitive to what is that dynamic between parents and child. So here are some new thoughts that he could glean from the passages that I've given him. Jesus is far more faithful to me than I will ever be to him, and he has promised that he will never lose me or turn on me as his family. John 6:37. Romans 1:16, I'm saved by the power of the gospel through faith alone, which means I cannot be condemned for drawing an upside-down cross. It's impossible. Romans 5, 1 through 5, I stand eternally in God's grace, and he judges me as a righteous saint, even when I make mistakes and even when I sin. And Jesus loves me so much that even before I became a Christian, he gave his life for me. How much more will he be faithful to me as a Christian, a member of his family? When I do something I know I should not, there is no reason to fear. I'm not saved by my obedience or my performance. I'm saved by a person, Jesus. I'm judged by his obedience, not my own. Because of him, I will never be condemned. And then finally, God is so committed to my redemption that he, by his Spirit, daily intercedes for me in prayer. Since he is for me, no one, not even myself, can undo what he has done to save me. Nothing in all creation can separate me from the love of Jesus, especially not a weird drawing. And this would become the spirit of our counsel. I would want him to begin, and we would probably have to go through many conversations, because I've dealt many times with believers who have these obsessional thoughts like this, or they think they've committed the unpardonable sin. And it's not as though we're going to read these passages and a silver bullet's going to hit him and his struggle will be over. Mark and I are going to be doing a lot of hard work together. And I'm not going to say he needs to embrace and begin to use every single one of these new cognitions to challenge his dysfunctional cognition. We'll collaborate together, and which one of these are most meaningful to him. And we begin to utilize things of this nature to begin to help him. Oh, two more. Hebrews 10, God judges me on the record of Jesus, which means everything that is true of Jesus is now in faith true of me. Jesus was perfect, so I am now also judged by God as perfect, even when I sin or make mistakes. This is the gospel. And one of the great problems that Mark has is he's not very familiar with this gospel. He's familiar with some legalistic rule that no human can keep, but not this gospel. I've placed faith in my own obedience in order to be okay with God. He's got to begin to recognize this. I place faith in my own obedience in order to be okay with God. That is misplaced faith that will harm me. My struggle is revealing that faith in the gospel alone will bring peace. And my hope, because I do believe when people sit with me and they want biblical instruction, I believe God is with us, and I believe the Holy Spirit is more committed to helping Mark than me. And I believe that even if Mark struggles to truly get over these obsessions, that I also have something to give him that can bring hope. Because his standing with God isn't based on him getting over OCD. Obviously, I want to help him do that, and that is my prayer. Among other things, throughout this process, I would be working with Mark to identify desires that capture his heart and feed his obsessions, his desires for approval on his own terms, acceptance on his own terms, his desire for perfection, and his desire for forgiveness that's already been granted. And that's all I have. Thank you.
The first question, sir.
It'd be a three-part question, real quick. All right?
I'm trusting
So
you.
you trust me, okay? All right, this is to Jeremy, is it?
Yes.
Jeremy?
Yes, sir.
Jeremy, are you familiar with the FOA Meadows gold standard research protocols?
No, sir.
That's standard in mental health research.
Okay.
It is obviously the gold standard. Does biblical counseling have any of research studies that meet the criteria for even coming close to the FOA Meadows standard?
I mean, I would say that there is a movement in the broader sphere of Christian soul care, Christian psychology, Christian counseling,
Right.
and biblical counseling would be in there as well. And they are vigorously pursuing evidence-based Christian care.
But since Jay Adams has been doing this since 1970, why hasn't there been any sort of peer-reviewed research studies along those lines? But it's really telling that you don't know what the Foa Meadows model is.
It's telling for you.
Well, for
not
any
so-
mental health person,
Well,
I would think.
maybe so. But it's a good question in that biblical counseling was birthed out of pastoral care, biblical pastoral care.
Right.
Jay Adams studied under O. Hobart Maurer, a very distinguished researcher. But he began to realize when you were in seminary during his day, when you went to get your counseling training, you were sent to a psychiatric hospital, and he realized there were tons of incongruencies with what he was being taught and what his faith, that were not congruent with his faith. So it was born out of pastoral care in the first movement. The second movement, we have some guys who, graduates of Harvard, graduates of the University of Pennsylvania, who were formerly in the mental health world, but they left that world, dropped their license, went into seminary, and continued the work really for churches. How do we equip the church to do the work of the church, to care for people, not to just...
So if there's no research base for this, how do you know you're doing any good?
Because my final epistemology is not research. My epistemology is Scripture.
And so,
And so,
but so how do you evaluate?
how do I evaluate?
How do you evaluate that you're doing good?
Because, I mean, Dr. Lack mentioned earlier that, it's not a scientific means of seeing that people do good. But
Oh,
when I
certainly it is.
But no. What I'm about to say to you.
Right.
When I see a person come in that's struggling with OCD and I see improvement in their symptomology, my assumption is they're improving. If I see a marriage come in and they are one day away from signing divorce papers and they turn on a dime, 180, and begin to reconcile their marriage and restore that, then something is
So
going on.
what is the one factor you've not controlled for in that observation?
I'm not really worried about that.
Placebo effect? You're not concerned about
I'm
that?
not concerned about that. If I
But
see
that's
people's...
what research tries
I,
to control for.
I don't do research. I
know, but-
counsel.
That's how you know is by research.
Well, according to your opinion,
Oh,
I think it's
we
it's
just throw
valid.
anything up against the wall then.
No, research can show us some things. I have already acknowledged that I embrace research. I read Dr. Lack's 2 of his booklets on mood disorder and obsessive compulsive disorder. It was wonderful, very helpful.
But they're books. They're not studies or research studies, right?
No. But there's a lot of research in these
Yeah,
booklets.
I would think so. It's
And
his
so
bailiwick.
we consult research.
Why don't you do it?
Because I'm a full-time practicing practitioner.
I mean, why doesn't the discipline do it?
Well,
I
I
mean,
think
the
we may
discipline
be
has-
moving in that direction. Actually,
Well, it's about time. Yeah.
Well, I don't, sir. I can't be held guilty for the history of the biblical counseling movement
Well,
not doing
you know,
research.
I mean, since
I think that's a
1970.
little irrational. That's not.
Pardon me?
It's irrational to hold me
I
responsible.
didn't, you being collectively the
Right, and I am making an influence. I'm probably one of the first licensed professionals who does what we do, and I do have a desire to bring this more into the professional realm, and I welcome research.
well, good for you.
I welcome it.
All right, we'll see how that goes.
Thank you for your question.
That was pleasant. Would you put that over there? Here we go.
All right, wind it up.
Dr. Lelek,
Yes, sir.
and also Dr. Lack, thanks so much for your presentations here. Dr. Lelek, it's really encouraging to hear from you just now that you're interested in moving this into a research direction, even though it may not have been in the past. That's commendable. That's really great. And it seems to me that we have this fantastic opportunity here, right here on stage. We have a proponent of evidence-based care and someone who's interested in perhaps doing some evidence evaluation of his own novel technique. I'd love for you both to just sort of spitball between the two of you on stage how one might start to go about researching biblical counseling.
That's great. Yeah, someone actually walked up to me in the audience and said, wouldn't it be cool if we collaborated on something like that?
Yeah.
But you're
And I said, Jeremy's hair is way too good for us to collaborate. He makes me look even balder.
I'll stay closer.
Thank you. Well, but then my beard looks inadequate, Ezra. Thank you. Yeah, I mean, I think, this is a thing that in many of what I would call our non-evidence-based fields or our poorly studied fields, one of the big things that we see is that when someone is doing something, they want it to work, right? They want it to work, but unfortunately, a lot of times they don't have the background to know how do I determine if it actually works or not. And that's one of the reasons why during my presentation I talked about, like, here's how we actually know if something works or not, right? We have to control for regression of the mean. We have to control for placebo effects. So if we were doing some sort of a clinical trial, typically what we do in clinical trials is first we have small scale studies, right? So we're talking maybe 10 to 15 people that come through and, I think my mic's coming in and out, sorry. That come through and are given a particular treatment. Typically that treatment is very heavily what we would call manualized, meaning we know what we're doing session to session, we know what the end goal is, we know about how long it's going to take. But with any of these, you also have to have what we call idiographic concerns, meaning if someone comes in who's Christian versus Muslim, who's African American versus Asian American, you have to take those sort of intra-individual things into account. But first you have to see, does this actually work in a small scale study to be able to typically then get funding for your larger scale studies. So with something like biblical counseling, I think what we would have to do, because it looked like there was several major, and correct me if I'm wrong, Jeremy, several major organizations out there that are credentialing people and things like that. So there's the one that you're the president of, but then I think there's like 2 other major ones. Is that right?
That's correct.
So what we'd have to do is we would have to have basically those 3 organizations and the top people in them essentially come up with a treatment protocol for not just problems, but for a very specific kind of problem. So whether that's major depressive disorder or generalized anxiety or something like that, something that we know we can measure and measure effectively using either self-report, other report, biobehavioral assessments, which is a thing that we can do now. Something that we know, like we can show differences for people who are and are not afflicted with this problem. And then we would have to take your manualized, formally operationally defined treatment and apply that to this population in a controlled way, randomized, placebo-controlled, double-blinded, to be able to see, does this work, right? Does this work or not? Now, correct me if I'm wrong. One of my guesses is that between those different organizations, there were probably some fairly significant theological differences or differences in how they would then interpret the scripture. Is that
The 3 that...
the 3 major kind of...
Very close. Very
they're all
closely
very close.
aligned.
Okay,
Yeah,
well, that's
they
good
are.
then. That's good. So maybe they could come to sort of operational definitions then fairly quickly, which is often the major problem. But then we would have to have clinicians who are trained in that. So it's not just trained in biblical counseling. It's being trained in applying this particular type of biblical counseling to this particular type of problem. And then we would have to run that. And ideally, we would want something like, depending on the treatment we're talking about, 50 to 100 people in that to establish, like, this seems to work, at least in this study. Now we follow up with it. And that's something that clinical psychology struggled with in its early days. And I was talking to, actually, Dan earlier, that, for me personally, I don't care what kind of therapy somebody does if said therapy works. And if we know that it works. Not just I feel like it works, but if it works, I'm good with it. So I may not do that kind, but I'm good with it. So if something like that happened and, let's say that biblical counseling for major depressive disorder was found to be effective, like an evidence-based practitioner would say, great, now we have another tool to be able to use that. None of that's happened yet. It sounds like you're saying maybe you'd like for it to happen, but we don't see biblical counselors, for example, in research universities, teaching in programs like that. This is all very much outside of that thing. So the chances of that happening are fairly slim, I would say, right now anyway.
Okay. Well, thanks so much. I look forward to that collaboration.
All right, thank you.
Brandon?
So my first question, Dr. Lelek, would you be interested in perhaps shaving your head for the collaboration? Just I kid, of course. So actually, Thank you both for this. I actually really enjoyed it. I have a background a little bit in both of your areas. I'm an ordained minister. I've worked in the church primarily as a youth pastor. I've done pastoral counseling, but I've also worked in the business offices of psychiatric mental health healthcare clinics. So I've kind of seen both worlds a little bit. And this question I'll direct a little more towards Dr. Lack, but Dr. Lelek, afterwards, if you'd like to add some thoughts, you're more than welcome to. It seems that in counseling, there's certain, I would say, philosophical issues that come up as well. So to make this question a little easier, we'll just make a mini case study based on students I've dealt with. Let's say you have kind of the teenage, depressed, nihilistic type. This is someone who has come to believe that good and evil are nothing but preferences, that man is not really worth much of anything, that there's no real difference significant between an ant and a human as far as value goes. It's greatly affecting their relationships. They have trouble relating to almost any human being, whether family, friends, authority figures, whoever. So my question is, when you come across these sort of philosophical issues, either relating to who or what man is, or what good is or evil are, how from your evidence-based practice do you deal with sort of the philosophy that's driving these psychological problems?
Good. Great question. Thank you. So the first thing I would do is I would take away their access to the nihilistic memes page on Facebook, because it's just going to drive that more, right? Which is also a hilarious page on Facebook, by the way. But seriously, what I would first do is I would look at, what is it that you want to get out of therapy? Like, what are your goals, right? So my goals might be to not be so depressed. My goals might be to have more friends. My goals might be to have more appreciation of life, right? And then what I would do is I would look at the literature and say, what is it that's out there that's most likely to help us achieve said goals? Okay. Now, I'm not going to impose my philosophical worldview on someone, right? Like, that's not a thing we do as ethical therapists. What I would instead do is see, where is it that you want to get? So let's say this person is now, and we see this not infrequently in our adolescents, right? This kind of like, I read 5 Nietzsche's quotes, and now life is meaningless. And I would say, okay, well, let's talk about that. Let's figure that out. So is life actually meaningless or not? Let's do the research. Let's figure it out. And that's up to you. All right, so what your goal is over the next week, first, we're going to do what we would call a behavioral activation project, which is, what's something that you used to do that you don't do anymore? Let's take some small steps to have you start working towards doing that thing again that you used to really enjoy, but now you've stopped doing. What sort of intrusive, automatic negative thoughts are you having that are causing you to feel depressed, to feel sadness? Life is meaningless. Okay, well, let's examine that. Is life actually meaningless? Say a person comes from a Christian background or a Muslim background or a non-theistic background. Okay, well, is it? Is it actually meaningless? What do you mean by meaningless? Well, there's no point to anything. Okay, so you should probably just, lay down and die then, right? Well, I don't know. Everyone should just lay down and die, right? Well, I mean, I don't. No, but if life is meaningless, we should all just lay down and die. No, what is the point of life according to your particular worldview, right? If they don't have a worldview, then I'm going to encourage them to find one. Go out there and explore different kinds of philosophical traditions, religious traditions, etc. Maybe that's part of your behavioral activation. But the whole point is, what are you not doing now that you used to do when you were feeling better? So therapy, to me, is about restoring functioning, right? And I often use the analogy of a flat tire. Who's had a flat tire before? All right, that's a lot of fun, right? So when you take your flat tire into the car shop, what does the guy do? He pulls the nail out of it, he slaps a patch on it, he airs it up, you're good to go. Does he ask, what sort of car were you driving? What was on the radio? How many miles have you driven this car? What's your mother's maiden name? What sort of car did she drive? No, here's the problem, the tire is flat. Here's something we know can fix that and make that better. And therapy, to me, is much the same way. In terms of, the problem is what you bring in that you can't do. Well, let's get you to be able to do that again. Now, do we have an evidence-based manual for existential crises? Kinda, because we have treatments for depression, and it turns out many of those are based on existential crises. So I would look to that and then move forward. I don't know. I'm taking up your time. Sorry. Go ahead and respond if you.
Thank you.
All right. Thanks.
So thank you. I think you actually kind of answered the question I was asking, so I'll modify it.
Sorry.
From what you have described in evidence-based therapy, I don't see how that precludes anything that Dr. Lelek was describing as well, because in biblical therapy, you can use the same techniques as far as the application goes. So he can use cognitive behavioral therapy or emotional therapy and other forms of therapies in it. I don't see, the only difference I see between what you guys were describing is a biblical approach and a secular approach. The other difference, and especially with respect to the secular approach, was that your approach lacks a telos, which is ironic because just right now you talked about functionality and having a end purpose. So the difference is, of course, not lack of telos per se, but a meta view about ethics and a meta view of ontology.
So we don't see that our ethics come from some sort of external source, right? So as a cognitive behavioral therapist, what I see is that there are certain principles in everyone's lives that serve to maintain, reinforce, or punish their behaviors. And those intersect with the thoughts that you naturally have to cause you to feel a particular way. So we have a telos, right? It's called behaviorism or social cognitivism. But we don't see it as some sort of externally given thing. We've developed through research, here's what we know about how humans work, and here's how we know to fix said problems in people when they're having these particular kinds of things.
Okay. To be clear, because I was going to say that, so essentially if you look at, because what you were describing, it seems like a kind of cognitive behavioral therapy approach, and if you look at rational emotive behavioral therapy as it first started, its influence came from Stoicism. And,
yes, very much.
Because and the irony about, well, not the irony, but the interesting thing about Stoicism is that it has a telos, but the difference is although they were theistic, deistic, their telos is naturalistic, or what they will call the natural law, right, as it is vis-a-vis human nature, having a comprehensive view of nature. And so they would have a worldview. I guess so what you just told me is that you actually have a worldview,
of course,
sort of a naturalistic worldview
so,
that you incorporate
so
within your...
We've got a theoretical background and perspective that drives our therapies, right? So it's not just, I'm doing this and we'll just see if it works. It's based on our research evidence that shows that these are principles of human behavior and human cognition. These interventions should work. Let's test it. And we test it and we find out it works or it doesn't work. And if it doesn't work, we throw it away. And if it works, we say, great, let's test it more. Okay. So we do have worldviews, right? There is a underlying theoretical, here's how people work. It's just not it's given from some sort of external source.
And so I have now just two minor questions for one of each. For you, suppose hypothetically somebody comes to you and he's obsessed with having sex with his sister, with his sibling,
sure,
or brother, it doesn't make a difference. And how would you deal with this? So this person both wants to have it and does feel guilty because of social taboos or religious taboos or whatever.
Okay.
So, and for you, how would you counsel or use therapy for a non-Christian? So, yeah.
Okay. Do you want to go first or do you want me to go first? Go for it. Okay. So if someone was actually having obsessions about that, which are very, very common, it turns out in OCD, our most common kinds of obsessions revolve around cleanliness, order, and then sex and religiosity. So I've seen dozens and dozens of people who had intrusive, unwanted thoughts about having sex with children, and they're an adult, or a member of their family or something like that. But the thing that would bring someone in is those thoughts then cause distress. So if someone's having distress from those thoughts, that means they don't want to have those thoughts. So then we would sort of do this exposure and response prevention therapy. Now what you asked was kind of a little mixed when you were saying if they were saying, I kind of like this, but I kind of don't. And in that sort of a case, I would not see them because that's not the sort of thing I deal with in terms of sexual dysfunctions or anything like that. So
it doesn't have to be sexual dysfunction. It's simply a cognitive dissonance that's going on in a person.
Yeah. So I mean, we would consider that like pedophilia or incest sort of things. Like they're very taboo in our culture and basically worldwide because of a number of biological functions, it turns out. And so we would...
Let's change it to say that a Muslim who wants to drink but knows the taboo of drinking in his culture.
Oh, okay. So Like, I would like to have alcohol, but my religion says I shouldn't do this. And someone comes to me and says that. I would say, well, then you've got a toss-up there, right? You have to choose between what I want to do versus what my culture is telling me to do. And as a therapist, I wouldn't say you should do one or the other. I should say, well, maybe you should make things like a decisional balance, which is a tool we use in motivational interviewing, to say what are the pros versus the cons of each one of these kinds of behaviors. So maybe I want to do this, but there's a lot of negatives, or I want to do that, but there's only one positive. And so I could use various kinds of evidence-based tools to help somebody come to a decision, right, on their own, but I wouldn't be imposing my own worldview or what I think they should do on them, because that's not good ethical practice. Sorry.
And my question was, how would I counsel an unbeliever?
Yes.
Someone that doesn't profess Christian faith? It's a great question. So as a counselor who embraces Scripture, I do hold to a high view of God's sovereignty. And so I'm trusting God to work in every person's life that walks into my office the way He chooses to work. And so if a person comes into me and they are not believers and they're adamantly opposed to anything of that nature, I do want you to know on our intake, we make it very clear the approach we're coming from, just so people have informed decision when they're seeking care. But if they still choose to come, and that does happen, I am trained as a counselor. And so my desire is to incarnate who I believe Christ would be relationally, in terms of profoundly compassionate, interested in their world, loving, kind, gentle, etc. I mean, I want to cultivate a relationship where that's my role. And then I would help them with their problem to the best of my ability, knowing that if they're going to refuse the gospel, if they're going to refuse relationship to God, at least in my worldview, it will limit their capacity for divine transformation. But we can get down the road in helping them not be so anxious or not be so depressed, or to help communication or something of that nature.
Thank you.
Welcome.
I have a question for Jeremy. In your last talk, basically talking about the case study that Caleb had presented, you mentioned something to the effect, correct me if I'm wrong, that because that person was not God-centered, that they would set themselves up for a lifetime of anxiety and issues over the span of time, right? So I guess my question is either directly or ostensibly, are you saying that people with religiosity, whether it's Christianity or a belief in God, have some inherent defense against anxiety? Because, and I'd like to see the research on that if you have that, because I don't agree with that.
Yeah. So I don't think that's exactly what I said. If it is, let me clarify.
Okay.
In the case study, this young man is a religious person. And his religious perspective was actually exacerbating his anxiety. Now, if I bring something different into his awareness biblically, my assumption is not that his anxiety will be alleviated forever, or that he's inoculated from even future OCD situations. I mean, a new obsession could pop up. So I'm not saying in any way, form, or fashion that a person embracing a gospel-centered perspective of life is inoculated from anxiety. Matter of fact, sometimes, this is where I think biblical counseling is helpful, because if a person isn't able to overcome the obsessions, and Dr. Lack and I both know we can do the best researched methodologies, everyone doesn't get better. Everyone doesn't even always stay better. But I can at least, if the anxiety persists, help people existentially navigate that struggle in such a way that would hopefully protect them from utter despair, that could hopefully provide some form of hope that even in suffering, the conformity to the image of Jesus Christ can take place. And often, the religious person may be far more prone to anxiety than the person who wants nothing to do with religion at all.
Okay.
And I think the techniques that Caleb is presenting, in my opinion, those are gifts of God. Those are things that God is allowing us to discover in the secular realm to help people. And so I think people in the secular community can definitely benefit from the gifts that Caleb brings to the table.
Thank you.
Hi, Caleb. I would like for you to address, according to, I guess, the secular atheist position on the nature of man. I'm pretty confident I might know Jeremy's position just based upon either a body, soul, spirit makeup of humans, and just where you're personally at, I guess, as a whole, where psychology would see itself. In terms of, and would you agree that the psych in psychology is actually the study of the soul?
No, because I don't think souls exist. So that's an easy question. So the psych in psychology is the study of human behavior, right? So the study of how it is that this collection of 80, 85 billion neurons in our brain somehow all work together to enable me to think, to act, to feel, to philosophize, to debate, to drink whiskey, whatever it is. Like, how does that work? That's what psychology is studying, how and why do humans do the things they do and act the way that they do. So for me, if you're talking about from psychology's perspective, as a science, so psychological science, what is the nature of humanity? That's not really a scientific question, is it? So the scientific question would be more of how are people similar versus different across different cultures, across different age spans, and so on. And one of the things that we know from tons of research is that people are more similar than they are different. So there's greater differences between me and any other member of my particular culture than there is between me and members of other cultures. Humanity is all very similar, which is why we can, for example, have things like evidence-based practices, because we know that there are certain laws of learning, there are certain ways that we have thoughts and cognitions, and those interact in a particular fashion. So that's the sort of question that psychology would ask and would say, well, we don't really ask that question, like what is the nature of man? Like that's not a scientific question. We would have to say, what is this nature? What are the basic aspects of personality that everyone has? And it turns out we ask questions like that and we see the big 5 factors: openness, conscientiousness, extroversion, agreeableness, neuroticism, and how people differ on these factors. Now, from a non-theistic worldview, I would say, if somebody asked me that question and asked me to answer this philosophically, what I would say is that everyone has the ability and the capability to act in certain ways. And that our natural biological dispositions in terms of genetics and epigenetic factors, our environment in terms of prenatal environment, external environment, all of those help to shape us into doing and acting the way that we do. So there is no nature of man or woman or humanity. Instead, what there is we have variations on a norm. So, for example, the vast majority of humans are heterosexual. But we know that there are variations on that norm, right? There's homosexuality, there's asexuality, there's bisexuality. So we have variations across that. And so you have to ask different questions about different things, right? Personality, sexuality, behavior, intelligence, things like that. So you can't really answer what's the nature of man. You would say, what is this aspect of humans typically like? And you can answer those kinds of questions, but not sort of those broad philosophical questions that aren't scientific questions.
So think they are scientific because the basis of science is reason, and
The basis of science is evidence. Reason supported by evidence.
sure, right.
So-
But the basis of it is evidence, and what I fear in psychology moving away from, I believe that the dichotomy between sacred and secular, or religious and secular, is a false dichotomy. That the dichotomy really is between the sacred and the desecrated. And so I think the Bible clearly teaches that everything, like every human being, is sacred and meant to be honored because they're made in the image of God.
But also we're apparently all terrible and have massive flaws and original sin.
No, but I
So that
think
seems a little bit of a dichotomy to me.
I'd like your feedback on
Sure.
this, but it seems the problem with reducing psychology away from the study of the soul to the study of behavior goes back to, well, then who defines what is correct behavior and what is incorrect behavior?
Sure.
The definition of sanity. And so if we lose the idea that there is a creator, that someone has intelligently designed human nature, that gets to define what is sanity and what's irrationality, then we're left with a floating standard for the definition of sanity and insanity, and leads to the rise of organizations like Nazi.
Oh, come on now. Don't start on
Well,
that.
no, like-
I think you were coming with a good question.
Well, no,
which
like-
was basically like, is there some sort of objective external reference for, let's say, sanity? Or is that what I would call a social construct? Meaning that it changes based on your particular culture that you're in, which is what actually happens. So, Jeremy, question. In the Bible, what's the definition of insanity?
Well, no, I think that there is
There's-
actually.
I mean,
So, I believe.
I put you on the spot, I'm sorry.
Yeah, no, I believe that the Bible clearly teaches that every single human being, to a certain extent, walks in various levels of insanity because sin, by its
To
by its
you,
nature.
for your interpretation,
No.
which would be different from other people's interpretations.
Yeah, no. I think the
Right.
Bible clearly teaches that sin, by its very definition, is the definition of insanity because what sin separates us from God.
Right. But that makes the assumption, of course, that there's a God in the first place
Sure.
that you would be separated from. So what I would say is that, from a secular perspective, what we have to understand is that here we are, all of us right here today, right? We are culturally, normatively agreeing on what is and is not proper behavior. So, who in here has any daughters? Raise your hand. How much are you going to sell them for?
Which one?
That's right. It depends, right? It depends. Excellent. That was a very common practice in the past that we now say that's abhorrent. We shouldn't sell people. Slavery has been abolished, for example. But that at the same time is something that in the Bible was considered a reasonable practice. So when we have things like that, we have to understand that our cultural norms change and therefore our morals change. So 150 years ago, if I happened to wander through Texas and someone greatly upset me, maybe they stole my house, I could shoot them and I would be fine, right? And everybody would be like, that's cool. Today, I did that, people would be very upset. Like, I would be put in jail, there'd have to be a trial, we would have to see all of these things, right? Now, did that change because of God, or did that change because humans have changed their moral standards? And I would say this is because they've changed their moral standards. If there were some sort of external yes, no, do it, don't do it, then that wouldn't change. I wouldn't be wearing cloth with multiple types of, clothing with multiple types of cloth in it, right? I wouldn't have eaten shrimp on the way down here or something like that, right? But those are morals that people make up, rules people make up, as opposed to these externally given things. What we do is we then interpret those in a different fashion. So, you, Jeremy, Ezra, you interpret the Bible differently today than you would have 100 years ago. Most of our Christians today would be considered heretics 200 years ago because of their belief systems. I think that's pretty clear that a lot of those doctrinal sort of truths have changed over time. that would label someone today being a heretic, where 100 years ago, 200 years ago, it would have been normal, and vice versa. So if you say, well, I looked at the Bible and it said I can own slaves, and you start owning slaves, that's going to be very problematic in today's society. 200 years ago, not so much, right? So when you assume that there's some sort of external given, then that, I think, puts the onus off of you to say, is this actually right or not? Is this good or not? And by good, do I mean, does it help people live a better life or not? Does it decrease suffering in the world? And so I would say that's what therapy is originally designed to do, is help you live a better life. And evidence-based practice shows the way to do that in the most effective way possible. Sorry if I rambled a little bit.
And I guess when you say better and good, according to what standard? Like, that's just what I'm getting back to.
Yeah.
Because the biblical worldview has an absolute standard, and it seems...
It's different for different people, though, so it's not absolute, right?
No.
don't have that view if we don't.
Yeah.
No,
Different people have different views on what is considered good and not good across denominations, across different sects of Christianity. So it's not really an absolute standard. It's an absolute standard for you personally, but it's not an absolute standard across everyone.
Right, but you use the term better and good, right?
Sure.
Which presupposes that there's a standard that exists. I'm just offering,
Yes.
like, according to an atheist secular view on psychology, what is the standard?
To decrease suffering, increase functionality, that's your standard. When people come into me, that's what they want. They want to feel better. They want to live a better life. They want to be able to do things that they can't do right now. And not in terms of my culture says I can't do this, in terms of this is what I internally as a person want to be able to do.
And so I guess source data, right? We had evidence-based, like, so what was that source that you would be pulling from?
So we develop measures, behavioral, self-report, observational measures. We norm those on the population, and then we compare how someone scores on those measures to their progress throughout treatment. So, for example, we have something called the obsessive compulsive inventory. It was developed, it was normed on everybody. We saw who has OCD and how do they score versus people who don't have OCD. And so that's one of the measures that we use to track progress. So someone comes into me, I give them the obsessive compulsive inventory. I say, woo, your score is really high. That likely indicates OCD. That plus all this other data tells me that you fit the diagnosis. Here's the treatment. Across treatment, what we'll do is we'll give that then multiple times. And we see, does that score decrease? Does it get back into the normal range? And we know the normal range not because of, the psychiatry gods came from Mount DSM and gave it to us. We know it because we've normed it on our populations, right? So that's where we get our good from, right? Our optimal from is from humans. That's how we get our norms. We don't have to rely on an external standard that differs, let's say, cross-culturally or between times. So.
Okay, thank you.
Sure, thanks, good question. I'm getting parched.
Thank you both for coming. It seems to me in the biblical psychology, a great deal of emphasis is placed on, is the patient God-centered? Would that be fairly correct?
Yeah.
Is there any sort of reliable, validated measurement to measure how God-centered a patient is? Is there any sort of normalized test you can give a person to find out where they fall on that scale?
A scientific tool to
Yeah,
measure how God-centered they are?
Yeah, a testing
No.
instrument.
No.
So really you never could measure...
Actually, I'm sorry. There are tons and tons of measures out there to look at different aspects of religiosity. Tons of them to measure tons of different things. Defensiveness, fundamentalism, closeness to God. There's tons and tons of those out there. We actually use them in a lot of my research.
But there's nothing theologically driven that would tell us what I'm talking about with regards to true God-centeredness.
How could you ever measure if you're successful then? Because you cure a patient, but you can never tell how God-centered they are.
So here's what I'm hearing in the last question, answer this question. My epistemology is not science. That's not my final truth. My final truth is God's sacred word, the scripture. And so when I'm talking to people about being God-centered, not God-centered, we talk about what is their functional faith? What kind of relationship do they have with God? What does that look like? What does that entail? We explore belief systems about God. We explore a sense of commitment to His Word, a commitment to studying His Word, reading His Word. Existentially, what is the ultimate driving force in their lives that tends to shape how they are in the world, living in the world? And so there are many ways to evaluate where a person is in their relation with God without needing a research tool or a scientific tool.
Are all of those just basically based on your opinion after evaluation?
I mean, are you familiar with qualitative research?
To a degree. I'm a layman. I'm not
All
a
right.
psychologist.
So there is, especially in our field, there is a growing movement of qualitative research where researchers actually enter into the culture and the experiences of people, and through various questions glean data that help them understand particular cultures, particular experiences of individuals within that culture. And so, and that just comes through asking questions and listening to people and gathering the data and creating, using systems to highlight and identify themes within those questions. So you don't always have to have an objective research tool to gather good data about people. You can do that, that's quantitative. You can also do it in a qualitative way, and it can be quite meaningful to the experience.
Thank you.
You're welcome.
Question submitted online for Dr. Lack. Dr. Lack, but didn't Dr. Kevorkian's patients desire to get better also? His last patient suffering from depression and overeating, and the prescription was assisted suicide to get better.
I don't understand the question. Sorry. Did they also want to get better? Is that what
Didn't
it
Dr.
asked?
Kevorkian's patients simply desire to get better?
Do they mean to decrease suffering? I guess that's what they're...
I'm going to presume.
Yeah. Okay. I wish they were here and we could clarify. Thank you, anonymous person on the internet. So I would say that they probably did, right? Like they desired to decrease their own suffering. They desired to, not necessarily increase functioning, but decrease suffering. I don't know what that has to do with evidence-based practice, but I imagine that probably is the case.
The word better is in parentheses, or in quotes, if that helps.
Oh, okay. So maybe maybe they feel like that's a negative way to get better, I would guess. But what I would say from a personal sort of secular, non-theistic perspective is that we would love for everybody to get better, right? But if someone chooses within the context of having full capabilities to say, no, I can't get better, or I'm having end-of-life issues, I'm going to die in the next 6 months and it's going to be horrible, then, who am I personally to say, no, you shouldn't do that. You should endure all of this suffering. Now, if someone is having, and we see this in mental health all the time, very disordered thinking, they're being irrational, illogical in terms of psychosis or manic depression or whatever it happens to be, then that's somebody who's not in their quote-unquote right mind, right? But if someone has, for example, some sort of terrible problems that's going to cause them more problems later, is it up to me to decide, yes, you have to subsist and consist in this way or not? I would say not. But that's just me. I don't know if that's what the question was trying to get at, but
Last question.
it's hard to tell.
Oh, hi. I'm actually a student at Southwestern Baptist Theological Seminary, and I'm studying biblical counseling. But I'm about to transfer to Westminster Seminary in Philadelphia, and I go to Forest Presbyterian Church. My name is Jimin, but I go by Maverick.
You go by what? I'm sorry.
Maverick.
Maverick, okay. Awesome.
I like the movie Top Gun.
Yes. I'll be your goose. Don't worry.
Oh, yeah, thanks. So I have a question for you, Caleb. There are so many different theories about human nature, I guess, in therapies. But, I just have a general question, do you believe human nature is good or bad? I mean, yeah. I mean, let me finish my question. So, I mean, I see in history. I mean, at least in my personal opinion, human nature is very bad. I mean, we have always fought wars with each other. Wars have never stopped, and their colonization and there's always fighting of wars. Even now, there are wars in Iraq, Islamic State, and yeah, you know, and not just wars, but you know, in my personal opinion, you know, there's Darwinism, and I mean, for example, in my personal opinion, what caused racism? I don't think it's, you know, the idea of slavery, because slavery has ended like in 1861, since, you know, the Civil War has ended. But still now there's still racism. Why? Because in my personal opinion, it's because we teach Darwinism in our schools. We teach, you know, humans come from different, you know, evolve randomly from different species, and therefore there's better.
Yeah. So I think I got your question right. So your question is basically, what do I, from a non-theistic perspective, how do I view kind of like human nature, right? Is it good or is it bad? Are humans good or are humans bad? I would say that humans aren't necessarily good or bad. Humans are, and that our culture across time shapes what we do. And I would say that today, right now, right here, humans are better than they've ever been. And we have enormous amounts of data to back that up. And one of the best sources of that that's coalesced together is a book by Steven Pinker called The Better Angels of Our Nature. And in this, he uses huge amounts of data from literally 30,000 plus years ago to today to show that humans today have higher standards of life, longer lives, lower amounts of violence, and higher amounts of wealth than at any point in our history. So when someone tells me today that they say things like humans are bad, wars still exist, I say, yeah, they do. Like, people do terrible shit. They do. That's something that's always going to happen. But what percentage of people are doing said terrible shit? And I think it's a pretty small percentage now. And it's dropping more and more and more. So if you look at, for example, wars, all right, are there a number of armed conflicts going around the world right now? Yes. Are they terrible and most can be avoided? Yes. Is it lower than at any point in our history? Yes. Why? Not because something changed externally, but because humans changed. And humans changed not evolutionarily speaking, we're the same we were 30, 35,000 years ago. They changed culturally, where those things are less acceptable now. It's less acceptable for me to beat my wife today than it was 50 years ago. Right? It's less acceptable for me to have an honor killing here in the United States, in the South, than it was 50 or 100 or 150 years ago. And I would say that humans are getting better, right, in terms of overall objective measures of betterness, and that's happened because of our culture. And it's not that humans are bad or good, it's what's the cultural milieu that you're in that causes you to act in particular ways.
Yeah, I guess I agree with you right there. You know, like, you know, yeah, there have been less physical violence in the world.
Sure.
However, I do believe, you know, still there are so many violence. Not just it's kind of like, you know, wars becomes cold wars. It's kind of like that because, you know, there's still there's still this mathematical model called game theory. You know, there's non-zero sum games. Yeah, of course. That's like you have mutual benefits with someone. You can be friends with them. But then there's also zero-sum games, which, I mean, I think basically the same thing as Darwinism.
And I would say your culture would determine how altruistic you're willing to be in certain sorts of situations. And that's actually borne out through anthropological literature and research. So it's not necessarily that some sort of external thing saying all humans act good, all humans act bad. It's what is the culture of the environment that I'm acting in. So Jeremy wanted to comment. So.
Yeah, so I think it's a good question.
Yep.
It's a philosophical question. It's a theological question. Obviously, a biblical theological answer is going to come to that question with the assumption that of original sin and humanity is born dead in his trespasses and sins. But we get lost in this question when we just start talking about war and people committing violence against one another. I've actually read the Pinker book. It's very fascinating how he chronicles with actual data that there, as far as violence in the world, it is less, which tells us where we've been. I mean, it is bad now. Look where we've been. But if we simply go in that direction, then we're really losing, from a biblical standpoint, what we need to be paying attention to in terms of good or bad. Okay? So this morning in church, our pastor gave a phenomenal sermon, and he was talking about a movement back 10 years ago, 15 years ago, where Christian young people were wearing purity rings. And the whole thing was they're going to wear this purity ring. They're not going to be sexually engaged until they're married. And he said that the theory behind it, like it's a good idea, but ultimately what it turned into is you had two young people who wore these rings who remained pure. And so the question that they tend or the conclusion they tend to reach is you have two pure people getting married versus two people who have committed a sin. And there's a danger in that because this couple over here that had no sex whatsoever is no more pure than the couple that engaged in sex 6 times a week, according to the standard of God. So the thing in our lives is when we become self-reliant from a biblical standpoint and we begin to assume because we haven't done the atrocities or we haven't committed the really bad things that suddenly we're in the category of good, in my worldview, we're mistaken. Yeah. So the question, are we good or bad, doesn't rest on behavior. It rests on an internal spiritual condition. And that, I think, answers the question that you're asking from a biblical frame of reference.
Yeah. Thank you.
Thank you. Closing statements. Wait, you have a question? Do you really? I didn't see you. I'm sorry.
Absolutely.
This is the last question.
Last question. Pretty simple. I don't know if y'all covered this before. I got here earlier. But in the current state of our world, as being a Christian, devout Christian, have been my whole life, how do you find that the media separates church and state these days? They cover what they want to on certain religions, and most countries are founded on a certain type of religion. So how do you find that the media covers a certain part of Christianity and different religions, and they separate them for how that they choose to cover them?
That's on topic?
It's not, but I'll actually answer it. How's that?
Yeah, that sounds good.
The media speak to the extremes. Had Dan Barker from Freedom from Religion Foundation come to a debate, and he and I had dinner the night before. We talked about jazz for 2 hours. And he turned to me and said, "You and I will never be on Fox News." And I'm like, "You're on Fox News." He goes, "Well, sometimes." He goes, "But what they want is the extreme. They want Westboro. They want the freak show to try and say that's the stereotype. And what happens is the majority, which doesn't behave like that, looks at that and says, that doesn't represent us at all." But in a world of 24-hour news, you have to have that to even get someone's 30-second attention span. So first time I've ever answered a question at an event. There you go.
Good job.
Thank you. Closing statement, 3-5 minutes, Dr. Lack.
Oh gosh, I have to talk for another 3 to 5 minutes? I don't know if I can do it.
You can do 2 minutes. There you go.
Okay. I actually had a 70-minute closing statement prepared, but I'll pare it down. That's right. I was playing the drums with it, and it was beautiful, but no, now 2 minutes. Here we go. If you're having psychological distress, mental health problems, marital problems, etc., what I encourage you to do is I encourage you to seek out an evidence-based practitioner of therapy, someone who uses methods that we know work, and we know that they work because we've tested them in such a rigorous fashion. I I'm happy if anyone wants to contact me to try and lead you to those folks. I keep a pretty huge database of those. You can also go through like Psychology Today, but one of the problems with that is you just have box checkers who check literally every single kind of theoretical orientation. They're like, you can't literally do 15 different kinds of therapies and have them be in any way consistent. So seek out evidence-based practitioners, do the research on what does and doesn't work. Some really great resources for that. If you have a kid, there's a website called effectivechildtherapy.com. And it's run by a division of the APA. And it is a fantastic website for that. And I would also encourage everybody to check out the Cochrane reviews, that's Cochrane, that have tons of great reviews on what does and doesn't work for various kinds of mental health problems. But if you're having a mental health problem, seek somebody out who's doing evidence-based treatment, because that's how you're most likely going to get better. There we go.
Dr. Caleb Black. Dr. Lelek.
Thanks for debating tonight. It's been great. I hope that tonight hasn't been too confusing in that Caleb and I used a lot of the same words, cognitions, feelings, kind of the case study sort of went in that direction in a way. But now to a large degree, I totally appreciate the kind of work that can help a severely anxious person become less anxious. But when it comes to what I would call deeper transformation on a spiritual level, where people don't simply learn methods that create a certain response, or methods that where the aim is the utility of the method, but people who really change inwardly at a deep level. Cognitive behavioral therapy will get you so far down the road, but it's not going to get you to that place, especially if you're a person of faith. And I would encourage you, if you're a person of faith, cognitive behavioral therapy may work to a certain degree, but if you're a person of faith, I would encourage you to seek out biblical counsel, because that counselor is going to be becoming very close to your worldview in terms of the assumptions about, I think, that are important questions. Who are we? Why do we do the things that we do? How do we change? How is God involved in that change? How does the gospel apply to that change? What is the purpose of change? And so cognitive behavioral therapy, in my opinion, can be effective for alleviating symptomology. But if you want the transformation of the total person at a spiritual level, I encourage you, don't stop there. Seek genuine biblical counsel.